time that took the ultrasound contrast agent to appear in the artery and in the extra vessel, the extracerebral district, as a thyroid tissue, allowed to exclude that the observed changes are due to systemic hemodynamic factors, or that the slower circulation outflow in MS may be secondary to a decreased arterial inflow. You can see on the left a case where the transit time is clearly delayed. The arrival in the artery is normal, but the time that the contrast takes to be recorded in the vein is about 3 times higher. In many cases, in the patients with multiple sclerosis, we found a cerebral circulation time longer than 10 seconds that we have never observed in normal subjects. A trend to increase circulation time was detected in patients with primary progressive multiple sclerosis compared with patients with other clinical forms of disease, but it does not reach statistical significance. It's possible to assume the difference is not significant for the small number of patients represented in the subgroup. No correlation was found between cerebral circulation time, age, and disease duration, the cross-sectional area, internal jugular vein in both patients and control subject. So the internal jugular veins are the main drainage pathway of cerebral blood in the supine position in physiological circumstances. And in patient with MS, the median time that the contrast medium takes to transit from the cerebral arteries to the vein was about 1 second longer than the control subject. The difference observed between patients with MS and control subject correspond about to 20% of a median value in control subject and more than 1 complete cardiac cycle. Our results are consistent with those of many studies that show the decrease in cerebral perfusion and the vascular changes associated with MS. Obviously, there are many possible pathogenic mechanisms, and there are necessary in other studies. The method that we use can also provide information of the type of venous drainage overall in the neck. Is in fact possible to obtain an imaging of all the vessels in the necks simultaneously. In this case, the examination carried out in the supine position is evident that the contrast medium, before appearing in the internal jugular vein, appears at first in vertebral veins and in thyroid veins and in the anterior jugular veins, and only after a long time in internal jugular vein. This is definitively an anomaly, and the confirmation of this case is the presence of obstructed internal jugular vein and activation of a collateral circulation. In conclusion, in our study, in comparison with control subject, patients with multiple sclerosis have significant prolonged cerebral circulation time. We have also found a more frequent retrograde flow and reflux of contrast in the jugular vein, and our findings indicate a possible real role of a contrast-enhanced ultrasound with CSCT assessment identification of subset of patients with vascular abnormalities that may increase knowledge in the pathogenesis of MS. So after our study, other authors have examined similar parameters, reaching the same conclusions. In this study, the authors used arterial spin labeling, that is an MRI method that allows non-invasive measurement of cerebral blood flow. When multiple delay time after arterial labeling are sampled, the cerebral arterial hemodynamics measure bolus arrival time. This parameter is defined as the time from labeling of blood in feeding artery to its first arrival in capillary network. So this is the artery capillaries time, has also been used in other studies. In this analysis, bolus arrival time was significantly longer in normal appearing white matter and deep gray matter in patients with MS compared with the controls. In the figure, a group averaged maps of bolus arrival time in the controls and the MS patients. Cerebral blood flow was also increased in this study in MS patients, and it was in normal appearing white matter. It was decreased in gray matter. This study extends our observation by demonstrating that the cerebral arterial hemodynamics measure is significantly prolonged in MS. They also found a significant association between EDSS and bolus arrival time. The authors state that the slower flowing blood in the arteries of patients with MS associated with the finding of increased cerebral blood flow could be secondary to widespread arteriolar vasodilatation, secondary to inflammation, or secondary to dysregulation of the normal mechanism of controlling arterial tone. I do not agree completely with this statement. I think that if an arterial vasodilatation may result in increased transit time with a small change in diameter of the arterioles, even an increased venous pressure normal is resulting in increased vascular caliber, even greater, and a marked decrease of a vessel cross-sectional area, and the flow velocity is inversely proportional to vessel cross-sectional area. Therefore, a vein dilatation should result in even greater slowdown in the flow velocity than arterial vasodilatation. The authors demonstrated, in fact, a slowdown of 0.1 second, while we demonstrate a slowing of the flow that is 1 second, much greater. Therefore, it is possible that the slowdown arterial capillary time can be only one aspect, and also a small effect of venous stasis. In another group of 56 MS patients and 13 matched health controls, the washout phase was evaluated. The parameters measured was area under the curve during washout and calculated from the peak intensity to the end of 1 minute acquisition, 1 minute residual value, and 1 minute washout rate. Internal jugular vein residual value and washout were significantly increased, and the washout rate reduced in patients with MS compared with healthy controls. Even after jugular vein with retrograde flow with reflux were excluded for statistical analysis, washout rate remained significantly lower in MS group compared with healthy controls. There was a significant association between age at onset, increased EDSS disability, and decreased washout rate in MS patients, calculated for each patient as the lowest value between the two internal jugular veins. That is, the values that take into account for each patient the more diseased vein. You can see here the difference of washout rate in this curve. This is a washout rate at 90%, and this is normal subject. This means that the contrast agent remains longer in the jugular vein of a patient with MS, with a longer time of emptying of the vein. Since the parameters of the washing in the vein are similar to those of normal controls, this should confer in objective, not operator dependent, the obstructive pattern of internal jugular vein. However, a deficiency of factors that determine venous emptying, such as a deficiency of a respiratory mechanism that act venous hemodynamics. So in conclusion, we utilize contrast enhanced ultrasound to describe the quantified internal jugular vein outflow in MS and healthy controls. This methodology reveals an impaired washout of a contrast agent in MS compared with matched healthy controls. The main results was that MS patients showed an average approximately 30% reduction in venous outflow through the internal jugular vein in supine position, measured as a washout rate percentage. These data are in agreement with other studies that showed impaired blood flow from the brain to the heart in patients with MS. The association of internal jugular vein washout rate with EDSS score suggests that outflow change could be related with MS disability and pathophysiology. time intensity curve reflects the inflow and outflow venous dynamics. They represent venous physiology and could be associated with the patency or not or venous in the neck or compression in the neck. Using time intensity shift analysis, it was possible to demonstrate this difference. But we now are tried to use the method also for evaluate the brain parenchyma with transcranial methods. Bolokinetic schematic representation, okay, thanks. I go to conclude. These are preliminary data. We are now evaluating time intensity curve at the level of a thalamus, lenticular nucleus, white matter. Using anatomical landmark to divide the ultrasound section in these following areas. After contrast, we are able to individuate at the reference point also the M2 segment and the lenticulostriatus branches. I can use the same methodology to quantify the intensity curve in different regions of the parenchyma, as you can see. Peak intensity and slope were significantly higher in middle cerebral artery than parenchyma region. The decreasing signal intensity that between thalamus, lentiform nucleus, and white matter can be due to different intonation depth. When we analyzed the correlation with the difference between healthy controls and MS patients, the time to peak was prolonged but not significant in patients compared with the control in all the ROI that we considered, whereas a significant increase in intensity was detected in thalamus and the lentiform nucleus and MS patients compared with the control. And these are our conclusions. We utilize also contrast imaging for parenchyma. The new method could be a new, easily available, minimally invasive bedside method for analyze brain perfusion in real time. Our data about the ROI curves in parenchyma ROIs need more studies, and fundamentally these results are preliminary, should be compared with the other quantitative techniques to assess brain perfusion like MRI. Thank you.
Thank you, Marcello. It would be interesting to compare some of those patients you have with significant time delays to see if they also have significantly reduced perfusion on MR, for example. Have you done yet a perfusion study with your time delay?
We have data about this, but we have not analyzed anymore. That we have about 100 patients that now we have studied, and that perform contrast imaging in extracerebral district and intracranial district with MRI perfusion. Yes.
Very good. So due to time, we're going to have to go on here to the next presentation. The next talk is traumatic brain injury and hemodynamic changes in the brain. And Jim Stone is going to give the presentation. He has a long background in working with traumatic brain injury, and particularly with the DoD in the United States, and has been recently involved in a major review of how to assess traumatic brain injury. So Jim, we're looking forward to your presentation.
Thanks, Mark. So today I'm going to give an overview of traumatic brain injury as it relates to the cerebral vasculature. TBI involves the brain as a whole and involves a number of different components across the brain, but today what I'd really like to do is just talk specifically about the cerebral vasculature. First, a little bit of background. Traumatic brain injury is a major global health issue. In the United States alone, there are up to 1.4 million emergency department visits. When we look at sort of all comers outside of ED visits, including visits to PCPs and other individuals who may not necessarily present to the healthcare system. It's believed that this number is actually up to 3 or 4 million individuals that are affected just in the United States alone every year with TBI. In terms of the types of causes for traumatic brain injury, we can see that falls are really the number one cause of traumatic brain injury, followed by traffic accidents and some type of an impact with an object in some form or another. We also know that there are at-risk groups for traumatic brain injury. So Dr. Hakey mentioned the military. This has been a big issue for the military over the last 10 years. In fact, the Defense Veterans Brain Injury Center did a survey a number of years ago of all deployed individuals coming back, and they saw that up to 10 to 20% of deployed individuals showed some sign of TBI. Now, these are not injured individuals. These are normal, quote unquote, normal individuals who are coming back. And so when we do the math on 1.5 to 1.8 million people who have been deployed, that number of potential individuals with TBI is quite high. TBI has also gotten a lot of interest when it comes to professional sports. And although we don't have a great understanding for the overall prevalence of traumatic brain injury in this population, it's becoming increasingly clear that professional athletes who have sustained many individual blows over time are at risk for developing chronic neurodegenerative changes associated with their traumatic brain injury. So traumatic brain injury is typically categorized into mild, moderate, and severe grades. Now, although there are many classification systems for describing these differing injury severities, many of them focus upon changes in consciousness, amnesia, whether the imaging is negative or positive, and then looking at a relatively gross measure that many in the room may be familiar with, which is the Glasgow-Coma scale. We also know that there are a number of different substrates that are affected in traumatic brain injury, from the neurons and glia to axons and the vasculature as well. And today, again, I'm going to be focusing primarily on those components of the brain that specifically involve the cerebral vasculature. Now, starting off first talking about the hemodynamic response that's seen in traumatic brain injury, this set of figures here is really a culmination of about 30 years of literature in the space of looking at the hemodynamics of the brain following a traumatic brain injury. And much of this literature is focused on moderate to severe TBI. But what's really been described is that there are 3 major phases of the way that the brain responds, the cerebral vascular response in TBI. And in what's been called the sort of acute early phase, which is really the first 12 hours following TBI, what's been observed is basically a very rapid drop in perfusion within the brain. And it appears that this rapid drop is due to an abrupt decrease in baseline cerebral metabolism. Metabolism and flow remains coupled within those first 12 hours, but really a drop in the metabolic demand of the brain in this first early period corresponds with a decrease in flow. Now, after those first 12 hours, it appears as if cerebral blood flow and metabolism become uncoupled, and that there is a significant hyperemia, so a significant increased flow across the brain. And then within the period, the late sort of subacute phase from 4 to 14 days, that's then followed by a profound reduction once again in blood flow, again in the context of uncoupling of cerebral metabolism with a relative hypoxia throughout tissues, which creates an entire host of secondary injury issues related to mismatch between metabolism and between supply through the tissues. Now, interestingly enough, the degree of the drop in blood flow that's observed in this acute early period is dependent upon the type of injury. So, for instance, in diffuse global cerebral edema, which is these dark bars along through here, it appears as if the degree of drop in cerebral blood flow is actually much lower than in focal injuries as compared to normal. Also, interestingly, in mild traumatic brain injury, it appears as if this three-phase phenomena of drop in blood flow, hyperemia, followed by, again, a sustained drop in blood flow, goes almost completely out the window when looking at mild traumatic brain injury. And this is a brand new article from Dr. Hakey's group looking at perfusion and susceptibility changes in a cohort of mild TBI patients. And across this acute to subacute period, what's seen is that there's actually an increase in blood flow across this period, and it corresponds to a drop in susceptibility reflective of an increased oxygen content in the setting of that increased blood flow within these patients. Now, it's unclear whether this represents a dysfunctional uncoupling of metabolism or whether this is some type of a neuroprotective effect, but it's certainly a very interesting observation in the mildly injured individuals. Now, I want to move on and talk a little bit about vascular reactivity following traumatic brain injury. And many in the room are likely quite aware of this phenomena, but the brain vasculature is very, very dynamic in that it's able to quickly constrict and dilate depending upon the metabolic demands of tissues. And this important property is what allows the vasculature to keep up with the metabolic demands of the brain as one area of the brain becomes active over another. In traumatic brain injury, there have been a number of studies that have shown that this normal vascular reactivity is lost. And many of these studies have been performed using this approach known as intravital microscopy, where a cranial window is created following a experimental traumatic brain injury, and there's the ability to be able to directly observe the Peel vessels on the surface of the brain, and importantly, not just observe those vessels, but also see how they respond to a number of different topically applied agents which would normally cause vasoconstriction or vasodilation. And this is one of those studies. This is a study that was published back in 2008 by Baranova and colleagues out of John Pavlichak's group, showing the normal vascular reactivity to acetylcholine here under a couple of different concentration conditions. And what can be seen here under following experimental fluid percussion injury is that there is a profound loss of this normal vascular reactivity to acetylcholine. Now, interestingly enough, this normal vascular reactivity was able to be restored by a combination of hypothermia, which is a long-studied therapy for traumatic brain injury, and also the free radical scavenger superoxide dismutase. Similarly, Oda and colleagues were able to show, again, this loss of normal vascular reactivity that was able to be restored almost entirely with the immunophilin ligand FK506. And Suhira and colleagues again showed this profound loss in vascular reactivity as measured by intravital microscopy that was able to be partially restored with hypothermia with slow rewarming versus rapid rewarming. Now, in addition to global hemodynamic changes and also changes in vascular reactivity, we also know that there's significant disruption of the blood-brain barrier that's associated with traumatic brain injury. This was a study that was published actually just last year out of Ron Hayes and Kevin Wang's group down at the University of Florida. And basically what they did was to perform controlled cortical impact traumatic brain injury in a rat model. And they then went through at a number of different periods following TBI, and they stained for IgG. Now, IgG, although it's abundant within the circulating serum, it really does not enter the brain under normal conditions. So it is a molecule that's excluded by the intact blood-brain barrier. So by going through and performing immunostaining for IgG, we're able to regionally detect and also localize the presence of blood-brain barrier disruption in this experimental model. And we can see that as early as 24 hours following injury and up to 3 months following injury, there is the presence of this extravasated IgG in this setting. Now, another thing that's been observed in traumatic brain injury is the peripheral infiltration of leukocytes following TBI. In the normal state, leukocytes such as monocytes, macrophages, and neutrophils are generally excluded, and the brain basically experiences immune privilege from the outside world. What's been seen under a number of different disease states and in TBI as well is that there is the infiltration of these peripheral leukocytes, and this in fact seems to be an active process. So CXCL1 is a chemoattractant for monocytes macrophages, and we can see that it's being actually actively secreted by endothelial cells following traumatic brain injury. Similarly, CCL2, which is a chemoattractant for neutrophils, is being actively secreted by activated astrocytes, as shown here. And interestingly, it appears as if both of these chemotactic agents correspond with the Golgi complex within endothelial cells and also within astrocytes as well. Here's a separate study that was published a number of years ago showing the active movement of neutrophils into the brain following a traumatic brain injury. And you can see these CD11B tagged neutrophils overlapping with secreted VEGF-A within the brain following a traumatic brain injury. Now, we've recently capitalized upon this phenomena of peripherally infiltrating leukocytes to develop PET imaging agents for traumatic brain injury. And this was a ligand that was developed at the University of Virginia, which we just completed a 4-year study examining in the setting of experimental traumatic brain injury. And essentially what we saw was that using this PET-labeled agent, we were able to very sensitively detect areas of peripheral neutrophil infiltration in an experimental model, and we were able to see this within the first hours to several days following TBI. This is a very interesting finding that we're now following up in a subsequent study looking at more globally at peripherally infiltrating leukocytes as potential novel imaging agents in the setting of TBI. Now, in addition to leukocyte infiltration and general blood-brain barrier disruption, there's also the observation of microscopic hemorrhage within the brain following TBI, and it's believed that this microscopic hemorrhage lies on the spectrum of blood-brain barrier disruption, certainly more on the severe end of blood-brain barrier disruption. And this is an important observation because there are studies that have actually shown that the presence of these microbleeds on imaging are a very strong prognostic predictor for for outcome following TBI. You can see here that these top two bars in the second two bars in the setting of microblades have far higher rates of death and vegetative state than the lower frames without lower frame here without any microblades or cerebral hemorrhage. And there's been major progress that's been made over the last several years in being able to visualize with exquisite detail these microbleeds in the setting of a number of different disease states. And this is another image from Dr. Hickey's group showing just the exquisite detail here that can be seen using susceptibility-based methods. And this is an area of real interest in TBI because it may be that this is a very important biomarker to look at for determining not only diagnosis but also prognosis following TBI. Now, I'd like to switch gears here a little bit and talk about cerebrovascular changes in the military following head trauma. Now, just like civilians that undergo impact and acceleration, deceleration types of injuries, military experience these types of insults as well. The one thing the military experiences that the average civilian does not is the addition of a blast shockwave to many of the TBIs that have been observed. Now, a blast shockwave is basically a shock front that is generated when a solid explosive turns into a gas. And there is a rapid expansion in the volume of space that this explosive will reside in once there is that conversion from solid to gas form. And what that does is that basically creates a shock front that moves forward in all directions from the charge. And this shock front is essentially a compression wave. It lies on the spectrum of sound and ultrasound as well, but it's a very, very intense compression wave that's capable of causing injury into and of itself. Now, military service personnel are exposed to a spectrum of blasts. There are military service personnel that use blasts routinely in normal operations, and this is not really considered a blast type of event. These are groups of individuals that we're actively looking at to see whether there's cumulative injury over time, but this is sort of on the lower end. Go to the far higher end, there are individuals that get exposed to blasts and IEDs where it's considered to be a devastating type of trauma, and these are generally pretty severely injured individuals. Now, when it comes to the cerebral vasculature, this is really a very underexplored area when it comes to blast and TBI, but there are some interesting things that have been seen in the few studies that have been conducted in these populations. This is one of the few studies that have been published on blast and TBI in the moderate to severe setting by Armando and colleagues back in 2006. And basically, Dr. Armando looked at 27 individuals who had moderate to severe TBI and performed cerebral angiograms on these individuals and documented their appearance on cerebral angiography. And interestingly, what he observed was that there was very significant vasospasm seen in these individuals that carried out to 30 days following injury. Now, this is about double the time of what's seen in civilian trauma. Typically in civilian trauma, vasospasm resolves around 14 days following injury. So there is a very prolonged vasospasm response that was seen in these individuals. And here are some of the examples of the type of vasospasm that was seen within some of the moderate to large vessels. Also seen was an increased prevalence of pseudoaneurysm formation as well, and that was, again, a unique feature in individuals who had sustained blasts. Another interesting finding was the presence of rapid and profound global cerebral edema. This was something which, again, was a very different time course from what's seen in conventional TBI. In conventional TBI, we're used to seeing cerebral edema out to 24 to 48 and 36 hours following TBI. And this is rapid cerebral edema that's basically developing within 6 hours of injury. And it was such a consistent feature of blast-induced TBI that many of the neurosurgeons are performing prophylactic craniectomies and cranioplasty in the appropriate clinical setting. Now, to study blast experimentally, many individuals use what's known as an air blast tube. And essentially what this involves is creating an air pulse that moves down the tube and exposing an experimental animal to that shock wave without any of the other secondary or tertiary effects. And using an air blast tube, basically blood-brain barrier disruption has been seen using IgG immunolabeling within the last few years by Garman and colleagues. This finding was replicated by Yeo and colleagues a couple of years ago, again showing positive IgG immunostaining following blast exposure. Also seen by electron microscopy by Steve Allers up at the Naval Medical Research Center is by performing electron microscopy following blast exposure, there is a noted profound truncation of the glycocalyx following TBI. Here is the control with the glycocalyx shown here, and again, a pretty profound truncation of the glycocalyx in cerebral vessels following TBI. Now, there are lots of different theories for how blast affects the brain, and there really are no clear answers at this point. There are some that believes that the compression and expansion of the thorax and abdomen following blast exposure causes a fluid pulse that goes to the brain and causes overexpansion of vessels. There are others that believe that there is a direct transcranial effect of the blast wave itself. And to sort of examine these differences, I and others have found it interesting to look at other examples of compression waves and their effect on the brain parenchyma and brain vasculature. And one example of that is high-intensity focused ultrasound. And although there are significant differences between a single blast overpressure wave and a repetitive application of high-intensity focused ultrasound, there are some similarities between the amplitudes and the frequencies between these two. And I'll quickly go through some of this in the interest of time, but this is a study by Heinen and colleagues out of Toronto Sunnybrook, and basically what they showed using intravital microscopy is that there was profound disruption of blood-brain barrier integrity, transient in nature following the application of a limited pulsive focused ultrasound. Also seen, interestingly enough, was transient, significant but persistent mild vasospasm following the application of ultrasound energy. McDaniel and colleagues showed that there is increased transcytosis ultrastructurally following focused ultrasound exposure, and there is also the loss of tight junctions, as shown by immunoelectron microscopy for occludin proteins following TBI. And I just wanted to comment here that although there is quite a void right now in terms of our general understanding for the natural history of TBI as it relates to blasts, we just received a contract to study the natural history both by electron microscopy, histology, intravital microscopy, and also imaging metrics over the next several years in collaboration with some of our DoD colleagues. So to summarize, TBI has widespread cerebrovascular impact on following TBI. It appears the response is correlated with injury type and severity. Alterations in vascular reactivity have been seen, disruption of the blood-brain barrier have been seen, along with infiltration of peripheral leukocytes. And it looks like there may be some special features of the response of the cerebral vasculature and blasts that we're hoping to further delineate over the next couple of years. Thank you very much.
Thank you very much, Jim. Yes, there's a question at the back. Steve? Steve, just a moment.
Thank you. It was really interesting. I think the subject of retraction of astrocyte foot process is something that is involved in a lot of these processes, and Jun kinase inhibitors have been shown to antagonize these. But is it going to, as far as therapy is concerned, is it going to be possible to deliver these things to the brain in traumatic injury?
Well, it's interesting you bring that up because, although blood-brain barrier disruption may be one of the major components of the secondary injury cascades following TBI, it may actually be a bit of a blessing in disguise as well, because we know that we have that window where there is actually an open blood-brain barrier. So that may also be a therapeutic window for the delivery of agents. Therapy in TBI is a pretty sore subject, though. Even though it's been 30 years of therapy for TBI, there's not been a single successful phase 3 trial to date. But hopefully with the improvement of some of our imaging metrics, which many believe is at fault for the failed clinical trials, we'll be in a position to make some progress over the next 5 to 10 years.
Just a real quick question. The decrease in perfusion that occurs pretty soon after, is that a result of metabolic uncoupling?
Well, it's actually metabolic coupling. So it's a drop in cerebral metabolic rate that's matched by drop in perfusion. And in fact, the basal cerebral metabolic rate is actually around 1.5 as compared to 3.5 in the normal state.
But you still consider that the coupling between astrocytes and endothelial cells is still there?
Well, as far as the integrity and the overall cellular features, I think that's a separate issue. But we know that there are some studies looking at hyperventilation and flow in those first 12 hours. And what it shows is when you hyperventilate these individuals, their cerebral metabolic rate remains constant, but their flow drops even further, which again suggests that there is coupling that's retained, but that coupling is lost after about the first 12 hours.
Great, thank you very much. Thank you, Jim.
It's a very pleasure for me to introduce the next presentation. It is Mark Haki, Professor Haki, that talk about the current state of MRI imaging method with and without contrast staging to study the microvasculature in the brain.
Thank you, Marcello. Well, we're actually a little bit behind here, so I'm going to try to focus on just a few things during my presentation and maybe integrate a little bit of venous, arterial, and cerebral spinal fluid motions in terms of what we can image. So my area of interest, you may know, has been looking at the venous system through susceptibility-weighted imaging, but also trying to link this to perfusion deficits to look at things like stroke, atherosclerosis, and a number of other diseases like that. So let me show you what's possible here. These are my conflicts of interest. So in the old days, we used to use SWI as a means to see microbleeds and veins because of the iron in them. So the veins show because they have deoxyhemoglobin. So we're able to use MRI as a very sensitive technique to visualize even small veins on the order of 200 microns, medullary veins, for example. This is easily done today at 3T. You can cover the whole brain in about 5 minutes in order to investigate that. However, it's not quantitative. So a recent development in the last 5 years has been quantitative susceptibility mapping, where we can now take the phase information associated with the magnetic fields that are produced by microbleeds in veins and produce the image on the right-hand side. So now, if you were to take the cursor, as I am here, and you were sitting at a computer and you pointed that cursor here, you would read that this is 450 parts per billion susceptibility. That translates directly into oxygen saturation. In fact, this image is an oxygen extraction fraction map of the brain. So you can now use susceptibility not only to measure iron content in the globus pallidus, not only to measure iron content in microbleeds, but also potentially to measure oxygen saturation. So a few examples here. This is an example of a dementia case. This patient was actually on Coumadin for reasons of cardiovascular surgery. Was having trouble. We then scanned him with SWI. He has cerebral amyloid angiopathy. So SWI is a very sensitive technique for finding even 50 to 100 micron bleeds in the brain. We've used it in traumatic brain injury to look at mild traumatic brain injury, for example, where we have found on the order of 10 to 15% of MTBI patients have some form of microbleeds or thrombus formation or some type of venous damage. And that might make sense because the venous wall is a lot thinner than the arterial wall, which means if you reduce the impact force, you may not get arterial damage, but you may still damage the venous system. And so we've now shown quite clearly that that's true in some fraction of these patients. Now, the other problem in gradient echo imaging in the past has been that when you see something black like this, you don't know what it's coming from. It could come from an air bubble in ultrasound. It could come from calcium deposition. It could come from a microbleed. But the advantage of susceptibility-weighted imaging today is it will differentiate between paramagnetic iron and diamagnetic calcium. So now MR is about to replace CT on that component because, as you can see in this image here, the susceptibility weighted image, you can now show that the negative component represents calcium. So here's an individual who had maybe a microbleed in the caudate nucleus. That would have been a really bad thing because it's actually a large bleed. But if it's a calcium deposit, it's not such a serious diagnosis. So being able to differentiate these is very important. Now, coming back to the concept of looking at the microvasculature and perfusion and the CVR that has been talked about so far, if you use SWI in the presence of caffeine, caffeine is a vasoconstrictive agent. So if we take the same person and we image them at the beginning without caffeine, and then we give them 2 cups of American coffee, then 200 milligrams of caffeine, you can see that the veins get much darker. And that's because they have a much higher level of deoxyhemoglobin in them. Because when you reduce the blood flow, the brain is still at the same CMRO2, it's still extracting oxygen. And so, of course, you now have a much higher level of deoxyhemoglobin. If we use the susceptibility mapping to quantify the change in oxygen saturation, we can clearly demonstrate here that there's, in the presence of caffeine, a 27% reduction in flow and a 10% change in oxygen saturation. You can do the same thing with Diamox, which has often been used for stroke studies in the past to create an increase of blood flow. And here you see a 40% increase in flow is required to create the same 10% change from a 70% normal level to 80% oxygen saturation in the presence of Diamox. So all these things can be done very easily today. And of course, both of these methods could be used to evaluate your patients to look not just for systemic or global effects, but to look for deficits. And I'll come back to that in a moment. Well, I'm going to skip this and just show you that we're now using a multi-echo version of SWI where we use a short echo and a long echo. Usually we've used a long echo to enhance the veins that I showed you initially. But the problem is when you have stroke, you get a lot of cases where you have thrombus and bleeding. And sometimes it's hard to differentiate what's thrombus and what's vein. So by using this short echo time, we can much more clearly differentiate the thrombosis because it has a much higher susceptibility. So here you can see nicely you have an obstructed right middle cerebral artery. You can see the thrombosis associated with it very clearly. And this is the short echo result and the long echo result. And we've also discovered recently that by using short echo, we can get this bright blood MR angiogram at the same time. And if you look very closely, you can actually see evidence for the vessel wall in the magnitude image. But now we can clearly show that the vessel wall is diamagnetic. So it will be possible to use this to study intracranial atherosclerosis, as our keynote speaker talked about yesterday. Now you can also do MR angiography, of course, so you can do this with very high resolution today. This is just a 3T scan in the presence of a contrast agent. Here you can see 100 micron vessels if you want to study stroke or look for microstrokes. This is 250 micron by 250 micron in plane resolution, 500 micron thick slices, and you can cover the whole brain here in about 12 minutes. But we'd like to do this without contrast agents, so we took this same concept of a double echo SWI, and what we did is we ran it twice, and the second time we ran it, we actually dephased the blood vessels. So this comes from the first time we run the double echo. This is the short echo. And then the second time, because we dephase the vessels, if I subtract those two pictures, I can remove the background tissue. And now you can see many of these very, very tiny vessels that you could only see with contrast before, you can now see without a contrast agent. So in fact, now in a single sitting, we can get these beautiful high-resolution MR angiographic images and the susceptibility-weighted images so you can study completely a stroke case, for example. So how can we compare this with stroke? If we look at a perfusion scan where we're looking at this delay time similar to the delay that Marcello was talking about, except we use mean transit time in perfusion to do that, you can see for the stroke patient, this territory here has been affected. If you look at the SWI, of course, you would predict that if the blood flow has been reduced, there will be a local change in deoxyhemoglobin, and sure enough, exactly in this area, you see this change in deoxyhemoglobin. You treat the patient, you scan them a week later. Luckily, this patient has now recovered. This complete recovery of flow here and a complete return to normal brain function under those circumstances as demonstrated by the changes in oxygen saturation. So just to summarize this component, now you can see here, this is a three-dimensional image. It's actually not an image of the veins directly. This is an oxygen extraction fraction map of the entire brain. The green shows you 70% oxygen saturation. The blue actually shows you the iron content in the basal ganglia and the midbrain. Now we can actually use this quantitative method to determine what is abnormal in terms of oxygen saturation. So we did this study where we looked at the cortical veins and we estimated the susceptibility in the cortical veins, which is the dashed line. And so most of these are less than 200 parts per billion because they're very small vessels. And then we also looked at a number of traumatic brain injury cases that had microbleeds, and most of the microbleeds lie above 200 parts per billion. That's about a 90% sensitivity and specificity. So this is an interesting case because it harks back a little bit to what we saw early with MS, but it's an intracranial hypertension case, and we know in IIH that you can get blockages of the transverse sinus, and here you can see that. And here you can also see evidence on the SWI of asymmetrically prominent cortical veins. And of course, that suggests change in perfusion. If we set this threshold at 200 parts per billion, all these areas in purple actually demonstrate reduced perfusion in the brain for this headache case, for this intracranial hypertension case. So now you can start quantifying this. So coming to the last two topics, we've just started to use SWI now to study vessel wall. This comes from a paper we published actually a few years ago in studying the peripheral vasculature. You can see, because of the diamagnetic effect of the wall, you can clearly see the vessel wall here, and you can see the atherosclerosis here in this fibrous cap. Here's another example in the carotids that we just started doing with a group in Korea. And again, you can see the same thing here. This is not vulnerable plaque. This is just an advancing atherosclerosis. And now we have a few interesting examples where you can actually see the thrombosis on the inside of the vessel wall. This is probably vulnerable plaque. So we believe that this is a pretty significant breakthrough in being able to differentiate the different stages of atherosclerosis. Because if this is truly a thrombosis sitting on the inside of the wall and just about ready to break off and become a thrombosis, it's now possible to actually say, we'd better go and treat this patient. We're having an annual meeting now on stroke in China, and perhaps this is something that could be married with some of the things with ISNVD in the future, and we have about half a dozen Chinese sites who are collaborating with us on this topic. Okay, finally I want to close and say, where does CSF come into this picture, and how can we use SWI and this sensitivity to iron to see what role do the veins play, or is it the arteries that play the role? So this neurosurgeon, Dr. Satish Krishnamurthy at Syracuse, has been studying this for about 10 years, similar to Niedergard, but actually before Niedergard. And he's been looking at the concept that the perivascular spaces that surround the microvessels play a critical role in transporting macromolecules out of the brain. And so his interest as a neurosurgeon is basically hydrocephalus. So we did a study here on rats where we induced hydrocephalus. So the upper row is normal rats where we can do the susceptibility weighted imaging and mapping. The lower level is a hydrocephalic animal. You can see now that if we inject iron dextran into the ventricles, we can follow the path of the iron dextran. And so you can see the iron dextran has built up quite strongly here inside the ventricle. And we have 3 time points, pre 1 hour and then 1.5 hours later. And this is basically my last slide. But this is, I think, a very exciting finding. The resolution in these rat brain images, by the way, is 40 microns by 40 microns. Still not high enough for what I would like to see, but enough for me to demonstrate the following. That in a normal animal, after you've injected iron dextran, you do not see uptake of the iron dextran in the venous system. However, after hydrocephalus and after you have waited from pre to post, an hour later, you can begin to see that the major veins are starting to absorb the iron dextran. How's it getting there? It's delivered through the CSF. The CSF delivers the macromolecule to the endothelium of the vein, and it passes through the vein and is carried out of the brain through the venous system. And you can see an hour and a half later, this has become much brighter again, demonstrating quite clearly that we can follow the distribution of macromolecules. So I think this is a very important way for us to begin to marry the whole concept of arterial inflow, perfusion in the brain, venous outflow, and the function of the venous system, not just the fact that it's carrying the blood flow out. So in conclusion, imaging arteries and veins is something that we can do fairly quickly now, even in a single sequence. We can begin to quantify oxygen extraction fraction. We can begin to look at things like vessel wall, and finally, we can start to look at the relationship between the blood flow and the cerebral spinal fluid. Thank you.
Thank you. My question, Mark, relates also to the previous 2 presentations. And have you been able to quantify transport and filtration across the vessel wall in order to determine, for example, some transport coefficients, transport parameters that can perhaps be useful for mathematical modeling purposes?
In the case of the hydrocephalus, I can probably give you some of those coefficients. In the normal case, because everything functions so clearly, I can see the uptake into the superior sagittal sinus, but I can't see the small changes like I saw here, for example. Because the system is so disrupted, it's slowed things down dramatically, and so it makes it possible to really study this carefully. But under normal circumstances, that would be difficult.
Thank you.
Thank you.
Thank you, Matt. The first speaker is Auguste Chabriat from Paris, that will speak about imaging of brain microvascular disorder lesson for CADASIL model.
Ladies and gentlemen, it's my pleasure to present you this talk about imaging of brain microvascular disorders and with lessons from the CADASL model. I would like first to thank the organizers for inviting me at this meeting, to thank Sabina Papata, who was my mentor when I started imaging research, for this invitation at this meeting. I would like first to start with CADASL. CADASL is the acronym for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It is a small vessel disease observed in large families, leading to small deep infarctions and diffuse white matter lesions. The disease is caused by mutations of a receptor, a gene called the Notch3 gene, which is located at the surface of smooth muscle cells and pericytes in the microcirculation. And this receptor is located at the surface, and all mutations of CADASL are observed on the extracellular part of the protein, on the extracellular part of the receptor. And we know today that CADASL is caused by an accumulation of the extracellular part of this receptor within the vascular wall. And you can see here the immunostaining with antibody against the Notch3 gene and this accumulation in small arteries and capillaries observed in CADASL patients. We know also more about the pathophysiology. After the accumulation of the Notch3 protein, other proteins will aggregate in the vascular wall. The TIM3 protein will be involved in neurovascular dysfunction, and other proteins such as the vitronectin and additional proteins will accumulate within the vascular wall, leading progressively to a loss and disappearance of these smooth muscle cells and pericytes in capillaries. The disease is summarized on this slide. You will have in this disorder T2 white matter lesions appearing between 20 and 30 years of age. Migraine with aura is detected before and after the appearance of white matter hyperintensities, and progressively patients will present with ischemic stroke and develop cognitive problems with executive dysfunction, and at the end stage of the disorder, severe dementia with motor disability and apathy. CADASL is an archetype and a model of pure vascular dementia related to small vessel disease, because cognitive decline is observed before 65 years of age, before the occurrence of degenerative disorder. It is of a pure vascular origin, and we have a genetic marker to prove the diagnosis. Here are the main features observed on MRI in CADASL disorder. There are lacunes that we can detect on T1 weighted images. White matter hyperintensities easily observed on T2 or FLAIR images. And also microbleeds as observed here in the brainstem, in basal ganglia, and sometimes in close to the cortex. Here you can see the spectrum of white matter hyperintensities caused by a small vessel disease with a young subject who is 20 years of age, and here a subject who is 60 years of age with these, you see the progressively extension of white matter lesions with the progression of the disorder. We know today that white matter lesions, the distribution of white matter lesions, is somewhat different from that we see in sporadic small vessel disease caused by hypertension. Here a patient with hypertension, here a patient with CADASL, and you can see that you have more white matter hyperintensities in the temporal lobes of CADASL patients, and also in white matter juxtacortical white matter in the frontal or posterior regions. We know also from diffusion studies that underlying white matter hyperintensities, you can measure variations of diffusions, and with increase of diffusion of different degree in this patient after a follow-up of 1 year and 2 years, you can see that underlying white matter hyperintensities you can detect variable degree of diffusion changes. The first question is how these white matter lesions are related to the clinical manifestations. For doing that, for evaluating this, we isolated patients only with white matter hyperintensities and who did not have lacunar infunctions. Here are different degree of white matter lesions, and we were able to show in a large sample of 64 subjects that white matter hyperintensities are actually related to cognitive performances, mainly with attention alterations and executive dysfunction. And also you can see here alterations of the TMTA, TMTB time, testing the executive functions and time-related cognitive performances. And we were also able to show that even if you have very large white matter hyperintensities, if we do not have lacunar infunctions, you will never see a patient with dementia. You will never see a patient with a severe disability, which means that extensive white matter hyperintensities have some weight on the clinical features, but cannot cause directly dementia. When we try now to determine whether the location of white matter hyperintensities has an impact on cognition, we were able to show that the location of white matter hyperintensities in the forceps minor or in the anterior thalamic radiations were in fact associated with processing speed in our patients, not in other locations. We were also able to show that in addition to white matter hyperintensities, when we use very thin slices of FLAIR images, we can detect between the cortex and white matter hyperintensities very small hypointensities caused by dilated perivascular spaces in the temporal lobes and in the subinsular areas in CADASIL patients. The specificity of these findings is very high, and we showed previously that the severity of these dilated perivascular spaces was strongly associated with the extent of white matter hyperintensities in this model, independently of age, gender, hypertension, and vascular risk factors. Therefore, we can draw now our first lesson. The distribution of white matter hyperintensities can vary in ischemic small vessel disease. The extent of these lesions is associated with executive dysfunction and processing speed in CADASIL, as observed in sporadic small vessel disease. Extensive white matter hyperintensities without infarcts cannot lead to dementia. The location of these lesions in the forceps minor and anterior thalamic tracts is associated with processing speed, and dilated perivascular spaces in temporal and subinsular areas are also associated with these hyperintensities. Now we can go to microbleeds. Microbleeds are detected in this disorder in white matter close to the cortex or in the cerebellum in 1/3 of patients in an ischemic small vessel disease. What is interesting is that we examined previously the location of these microbleeds, and we observed that microbleeds are not located as lacunar infunctions or white matter lesions in a small vessel disease. For example, in the cerebellum, we can see a lot of microbleeds in an ischemic small vessel disease, but we never see lacunar infunctions or white matter hyperintensities. And we also were able to show that the level of blood pressure and the level of hemoglobin A1C, translating the glucose level, were significantly associated with microbleeds in this disorder in patients who were not hypertensive and who were not diabetic, which suggests that blood pressure or glucose level can influence the occurrence of lesions in the normal range. And this is interesting since it can modulate the imaging phenotype of the disorder. We can see sometimes, but very rarely, intracerebral hemorrhages in this disorder. in a location where you can see microbleeds, but in most cases, there is in addition a very severe hypertension. The lesson 2 is microbleeds are detected in 1/3 of patients in CADASIL, as observed in ischemic sporadic small vessel disease. Their number is related to age and lacunar infarcts. Their location largely differs from that of white matter hyperintensities and lacunes. Blood pressure and glucose level, even in the normal range, can promote the occurrence of microbleeds in CADASIL, and hemorrhage occurs mainly with hypertension. We saw also ischemic lesions in this disorder, classically a lacunar syndrome with a small deep infarction. But what is interesting is that we had the opportunity to see also different cases after a stroke event with multiple ischemic lesions. And in most of these cases, blood pressure was very low with hypotension, which suggests that in a small vessel disease, you can have multiple ischemic lesions, possibly related to hemodynamic alterations. And this is not a current view in a small vessel disease field. Small ischemic lesions can lead to cavities, what we call lacune in the brain. We can segment these lacunes, and we demonstrated that the lacunar infarctions in white matter are in fact larger, their volume is larger than that observed in gray matter in a small vessel disease. Here is the location of white matter hyperintensities with the frequency of lesions in this disorder. And here the location of lacunar infarctions, and you can see that lacunar infarctions are mainly observed in the deepest part of the brain. What is interesting is that we did not see a clear association between white matter lesions and atrophy, but we were able to see that in these two patients, for example, who have a similar age, that lacunar infarctions are observed in relation with cerebral atrophy. And we showed that the lacunar infarctions and diffusion measures in the white matter were associated with brain atrophy, but not the extent of white matter hyperintensities. And we observed also in the same model that there were important morphological changes occurring at the cortical surface in this small vessel disorder. And we showed that the load of subcortical infarctions was strongly associated with the death of different sulci at the cortical surface in the CADASIL model. And we were even recently showed that after the occurrence of an incident lesion with a follow-up of these patients, that we can detect modifications occurring within the connected area in the cortex, with a thinning of the cortex appearing secondary to an incident infarct at the subcortical level. You can see here, after this small infarction, there was a thinning appearing at the cortical surface, remote from the subcortical infarction. And finally, we showed also that we can detect in CADASIL patients neuronal apoptosis in some layers, and particularly in layers connected with the subcortical areas. We also have the opportunity to detect some signal changes at the cortical surface in this small vessel disease, but this can be detected even before the occurrence of lacunar infarctions. This was obtained using 7 Tesla MRI, but we think that the signal changes observed in the cortex are related to other mechanisms, possibly due to demyelination or venous alterations. We need additional study to investigate this lesion. The lesson 3 is therefore that lacunar infarcts are frequent and detected in deep cerebral areas in CADASIL, that multiple ischemic lesions can occur simultaneously, that the volume of lacunes is larger in white matter, that the accumulation of lacunes is associated with cerebral atrophy and cortical morphological changes, and that cortical signal changes can be detected before, but they have probably another mechanism. When we try now to determine which of these markers are the most important for the clinical severity in this model, white matter hyperintensities, diffusion changes, microbleeds, lacunar infunctions, or brain volume, we showed that brain volume was the most important marker in this model of pure vascular dementia. Brain volume was explaining 35% of the variance of the global cognitive score using the Mattis Dementia Rating Scale, with only a small contribution by lacunes. That means brain atrophy is a major marker of a pure vascular dementia. And we showed that atrophy and sulky changes observed at the cortical surface was also strongly associated with cognitive problems. And you can see here the morphological features of cortical sulky associated with apathy, an important symptom of the disorder. We have also hippocampal atrophy in CADASIL patients. This is frequently observed at the late stage of the disorder. This is not Alzheimer's disease. This is a pure vascular dementia. And hippocampal atrophy was shown to be also an independent predictor of cognitive performances in this model. We were able also to observe a very small infarction within the cortex, which are called now microinfarcts, and this was detected using in a post-mortem study with an MRI, the duration of which was 12 hours using a post-mortem material. Finally, we can say that although white matter hyperintensities are associated with alterations in executive functions, disability, and severe cognitive decline are mainly related to lacunar infarcts and not related to white matter hyperintensities. And lacunar infarctions are associated with cerebral atrophy, and cerebral atrophy is associated with the clinical severity. Cerebral atrophy develops diffusely and can even involve hippocampal areas. Cerebral atrophy and cortex thinning appear mainly driven by the accumulation of lacunes at the subcortical level, and we can also detect cortical microinfarcts at the late stage of the disorder. You know, in the literature, there is a strong relationship reported between atrophy and white matter hyperintensities. And we didn't see this in our patients. And we wanted to go further to explore this problem. And you can see here patients of similar age, and you can see that the higher the volume of white matter hyperintensities, the smaller the ventricles, which suggested that there was a positive association between white matter hyperintensities and brain volume in this disorder. And when we isolate lacunes, we can see that white matter hyperintensities is in fact associated with an increase of the brain volume. And we had the opportunity, using new techniques such as machine learning methods, to classify the voxels of white matter hyperintensities. And we found recently, this has not published yet, that there were two populations of white matter hyperintensities in this disorder. The population of white matter hyperintensities located in the frontal areas and temporal lobes, and those who were located in periventricular areas. And we showed that the white matter hyperintensities in the temporal lobes in juxtacortical white matter were associated with an increase of brain volume, were not related to lacunar lesions, were less associated with microbleeds, were associated with an increased brain volume, and were not associated with the clinical severity, in contrast to white matter hyperintensities in periventricular areas associated with lower degree of extent of white matter hyperintensities, with a higher volume of lacunes, a higher number of microbleeds, decreased of brain volume, and a more severe clinical status. And we came back now to these different white matter hyperintensities, and using the true T1 and true T2 on 7 Tesla MRI, we were able recently to show that the T1 and the T2 under white matter hyperintensities differ between these different regions. We also, using 7 Tesla MRI at very high resolution, observed that associated with the dilated perivascular spaces, there might be small cavities in white matter lesions located at the juxtacortical level. And this suggests that hyperintensities are not related to demyelination and axonal loss as usually thought. In the mice model of CADASIL, we recently detected that in the white matter there are vacuoles of water with preserved myelin, I have finished, preserved myelin and preserved axons in the white matter, and which suggests that there is an accumulating evidence now suggesting that white matter lesions are in fact heterogeneous, that intramyelinic edema may be present at the early onset of white matter hyperintensities, and that mechanisms underlying white matter lesions may vary in different areas in CADASIL. My conclusion is white matter hyperintensities are heterogeneous and probably related to different underlying mechanisms in small vessel disease. The accumulation of lacunes is responsible for cerebral atrophy and explains the severity of ischemic small vessel disease. Major cortex changes can occur after accumulation of subcortical ischemic lesion in small vessel disease, and cerebral atrophy is the MRI marker most related to clinical severity in small vessel disease. I would like to thank you for your attention and to show here the different teams working on this topic since long years. Thank you.
Thank you for a very interesting presentation. But then the question in the end for the patient is, can you do anything for them?
For CADASIL patients?
No, for patients who have something like...
amyloid angiopathy.
Yes, exactly.
Well, the treatment is related to the disease, and we have different ideas for treatment. For example, in CADASIL patients, there is now studies evaluating how we can suppress or reduce the amount of Notch3 protein within the vascular wall. And therapeutic trials have been started in animal models, not in humans. For amyloid angiopathies, as you know, the same approach as used in Alzheimer's disease is also now started in some teams to try to reduce the amyloid deposit within the vascular wall. I think also that an important aspect is blood pressure. And we know that the risk of hemorrhage even in amyloid angiopathy is related to blood pressure. And one idea, and we have this idea with Steven Greenberg in Boston, is to reduce blood pressure, to reduce the risk of recurrent hemorrhage in amyloid angiopathy. And we are working on this topic.
Thank you very much. All right, so we're going to continue with the next two presentations, both of which are given by Clive Beggs. The first one is internal jugular vein cross-sectional area. These are a little shorter presentations because they're covering two separate topics as from the posters and the presentations. So Clive, please go ahead.
Thank you. Thank you for inviting me here. The work that I'm going to present in this first presentation is really being done jointly with Robert Zvadnov's team in Buffalo. And I'm going to be looking here and presenting work that we've done on the internal jugular veins, the cross-sectional area of the internal jugular veins, and the relationship to the pulsatility of the cerebrospinal fluid in the aqueductus sylvius. And I'd like to acknowledge the other members of the team who have been involved in this. Now, for a long time, we've been looking at CSF pulsatility in the aqueduct of Sylvius and seen that it's different in MS patients and also in healthy subjects. And what we found with the healthy subjects was it appears to be related to constricted venous outflow. The pulse basically gets more the amplitude of the pulse gets greater when the venous outflow is constricted. But we didn't understand why or what was going on. So we kind of pursued that. And so what we did in this study is we got 98 relapse-remitting MS patients and 99 healthy controls who we age-matched very closely. And then we looked at the area of the cross-sectional area on the left and right internal jugular veins on the outflow, and also looked at various, I think 4 variables really, that described the nature of the flow in the aqueduct of Sylvius. And you can see on the internal jugular veins, we looked at, we took measurements at the C2, C3 level, C4, C5, C6, and C7, T1 levels. And here are the initial univariate results. I'm sorry, this is not coming out very clearly on this for some reason, but that doesn't really matter. What you can see is that there's no significant differences really for anything, except for when we look at the lower neck on both the left and right side of the internal jugular veins. The MS patients have considerably smaller cross-sectional areas, and this is significant. Notice also that as you go down towards the thorax, the actual area of the jugular veins increases in both parties, but not as much in the MS patients. Now, what I did here was I used a new technique to me anyway, which isn't used often, partial least squared correlation, which enables us to look at whole groups of variables. And really, it's kind of like doing multiple linear regression, but actually doing with tables. And so we could look at all the variables in the pulsatility of the cerebrospinal fluid and all the variables in the cross-sectional areas of the neck, of the internal jugular veins. And we could see the relationship between the two and how close those relationships were. And so this line, this measured line, what we call inertia, it's singular value inertia, the more it's over to the right, the stronger the relationship. This probability distribution is the random distribution you would get for the frequency distribution if it was just a random response. And you can see these are the healthy controls. Again, it's not come out on this slide, unfortunately. These are the healthy controls. This is the lower neck. This is the upper neck. And you can see there's a very strong relationship between the pulsatility in the cerebrospinal fluid and the width or the area of the cross-sectional area of the veins in the lower neck, which gets less strong in the veins in the upper neck, and it completely disappears in the MS patients. We then did some correlation analysis just to look at this in more detail, and what we found was this was net negative flow towards the spine, this is net positive flow towards the lateral ventricles, and you can see that there's quite a few statistically significant relationships, correlations in the healthy controls, but that drops off considerably in the MS patients. And the other thing that's really interesting is that all the strongest relationships in the healthy individuals are with the left internal jugular veins, whereas with the MS patients, those relationships are really completely destroyed, and it's the ones with the right jugular veins which tend to be more stronger in that group. So we can say that there is an association between the cross-sectional area of the internal jugular veins on both the left and right sides of the body in the lower neck with the aqueduct of Sylvius in healthy individuals, suggesting very strongly that there's a biomechanical link between these two effects. But this relationship is profoundly altered in MS patients. So what's it mean? Well, naturally, the internal jugular vein, as you go towards the thorax down this end, it increases. But why would we see larger veins to do with patients or individuals who've got larger pulsatility? Well, I think we could look at Paolo Zamboni's work on the thoracic pump. And what you see here is he observed the same trend in terms of increased cross-sectional area towards the thorax. But when the individuals increased their interthoracic pressure through a kind of Valsalva maneuver, you saw that the veins in the lower part of the neck, they dilated, they increased, because the flow was decreasing into the thorax. So that seems to give a good clue to what might be going on. And in fact, having looked at the other literature in the area, we start to see that when the interthoracic pressure increases, the thoracic pump certainly is inhibited. And what we see is that that we get more jugular reflux, interestingly, in the left internal jugular vein, which is the one which was mostly affected in the MS patients. And we see that there seems to be a relationship between increased interthoracic pressure and increased intracranial pressure as well. So this suggests that certainly in the healthy controls, there's a relationship between the interthoracic pressure and the motion of the CSF pulse, which is being reflected in the diameter of the jugular veins. But what's going on in the MS patients? Well, we also looked at body mass index in here, but I'm not going to say too much about that because that was mentioned in Chris Magnano's paper that was published in Veins and Lymphatics. He found exactly the same thing as we did, that the body mass index, as that went up, so the area of the jugular veins seemed to increase. And this happened in both the MS patients and also in the healthy controls. So we saw that the effect was similar in both cases. And what we surmise from this, that it's really probably fat accumulation on the chest wall that's inhibiting basically the thoracic pump and increasing the cross-sectional area. So we suggest that happens to both the healthy individuals and the MS patients. So why the breakdown, this breakdown in the relationship between the jugular vein cross-sectional area and the pulsatility of the cerebrospinal fluid in the MS patients? And what we can suggest, there's two possibilities here. The ventricles may have enlarged in the MS patients so that the characteristics of the cerebrospinal fluid pulse will have changed. Or conversely, it may be that the narrowing of the internal jugular veins in the lower neck in the MS patients, which is probably due to collateral flow further up the system, is just changing that relationship. So you start to have a kind of metric that can be used to differentiate between these groups of patients in looking at this relationship. So it seems that there is something definitely going on that's different in the MS patients. So my conclusions are that there's a biomechanical link between from the interthoracic pressure via the jugular veins, and that causes a functional stenosis, not a stenosis. Notice the veins are wider, but the veins dilate, but the flow is reduced. That flow is reduced, as we'll see in my next talk or later on this morning. I will show you how that impacts on the aqueduct of Sylvius later on. In the MS patients, that relationship is clearly broken down in some way. So that's extremely interesting, what's going on there. But both the patients seem to be, both MS patients and healthy controls seem to be influenced by changes in the interthoracic pressure and BMI. Thank you.
Thank you, Clive. So we'll go on to your second talk and then we'll have questions. So the next talk is blood storage within the intracranial space and its impact on CSF fluid dynamics. And there we go.
Now I changed my hat here, and now I'm working with Marcello Lagana's team up in Milan. And this really is another branch of my work, really with a lot of signal processing. I basically like numbers and like mathematical modeling. And you're going to see this here, and later on you're going to see how I bring the two together. Really, one of the things that has been I've been wrestling with for a long time is what happens to the transient storage of blood in the brain, and how can we actually map that and see what's going on. So I'm going to present a methodological paper here with a new methodology, which is for the first time presents the transient storage behavior of blood, venous and arterial blood in the brain. And I'd like to thank the other members of the team who are involved in this. Now, the brain has got a wonderful mechanism. It's a fluid machine. I'm an engineer. So from an engineering point of view, this has got to work in a fluid way. The fluid mechanics has got to work. And we have a Windkessel mechanism here, so that during arterial systole, when we have maybe 40% more blood, a big peak going up there, we have to somehow dissipate that extra volume of fluid so that we can have smooth flow through the capillary bed in healthy young adults. So what happens is it displaces cerebrospinal fluid out through the foramen magnum, which then comes back in diastole and kind of equalizes everything up in a way that we fully don't understand until I present the paper. And then you get kind of energy put back into the pulse in the venous side. So what's going on here? Well, clearly, this is Ambarki's work that's published. Clearly, there's storage going on here. At this point in systole, we've got more blood going into the cranium than's coming out. We've also got a delay in the peak between the arterial and the venous, which is extremely strange from a mechanical point of view, because these are incompressible fluids in a rigid container. So how on earth can you have a lag? And then in diastole, you've got more going out than's coming in. And of course, this is reflected in the cerebrospinal fluid pulse through the foramen magnum, where it's pushed out in systole, and it goes back into the cranium in diastole. So we're all familiar maybe with these flow measurements that are taken across the cervix. The trouble is, how on earth do we get... It just doesn't work from a fluid mechanics point of view. These are incompressible fluids. How on earth can you get delays in any way? So what's going on inside the cranium? That's been my quest for some years now. And basically, I've cracked it, so we're going to see it. So what we did was we took 14 healthy adults. We kept them young, so they're under 35. And we did, we took MRI across the C2, C3 to get the flows in the neck. And later on, we looked at the aqueduct to Sylvius, but that's in my next talk. I won't go on with all the results that are there for you. The important point is we saw, as we would expect, the arterial peaked first, followed by the peak in the caudal direction of the cerebrospinal fluid, followed by the peak in the venous. And that's the aggregated flow of the 14 individuals. And you can see that they follows what we'd expect. We get the peak here in the arterial, more blood going into the cranium than coming out of it, followed by the peak here in the other direction in the cerebrospinal fluid, followed by the peak in the venous, and then we get less blood coming out in diastole in there than going, more blood coming out of the cranium than going into it. So some interesting things going on there, but this does not work to me. I'm not happy with this as an engineer. This is not how machines work. There's lags in it. It's very difficult. This is all extracranial. And now I'm going to show you what I did. We know that the system is all related to each other. Something here will have an effect on something up here, because you've got this blood being pushed out by this in the PL arteries, the blood being stored in here. So we know blood is being stored there. We also know that the cerebrospinal fluid impinges in some way on the cortical bridging veins. So how do we put it all together? I think I've said that there. Sorry, this is the arteries, the PL arteries. They expand during systole to store blood, so you get a smooth flow going through the capillary bed. And then in diastole, the CSF compresses these to make up for this drop here, so it continues the flow through here, so it's smooth. And Vignes, this is the important paper in this, there's one or two others, did some histological work and kind of found a sphincter at the end of the cortical bridging veins, which suggests that this cerebrospinal fluid impinged on here, causing the blood to build up in here before being discharged. So what we did was we assumed that the flow through the cerebrovascular bed was smooth, and steady. And what we then did was looked at the difference between the instantaneous flows in, and we did the summation of the changes in volume. So these expand in the arteries and the veins expand. So this is our model. So we can build up temporally what's going on. I must say, I cannot tell you what the absolute volumes. All I can tell you is what's the relative change in volume. And so this system, which to my mind is very unsatisfactory because it's the extracranial flows and doesn't make much sense in some ways, and many people have tried to understand it, becomes that. And that's never been done before. And that looks like a machine that works, because we've got incompressible fluids that are very, very closely coupled, which is what we'd expect. And we'd see parabolas. As one thing increases, something else decreases. Remember, these are incompressible fluids. So nothing can be squeezed and change its volume. If some vessel wants to expand, it must displace something else. And so what we're seeing here in systole, as the cerebrospinal fluid starts to come back into the cranium, it changes its flow, so it compresses the arteries. And so the volume of the arterial blood in the brain starts to decrease down to a minimum in diastole. As this increases, that gets squeezed out. But notice what's happened to the venous. The venous at some point starts to collect. So there must be some mechanism. This is supporting the mechanism of Vignes here, that something there's a mechanism mechanically causing the blood to start to store in there. And that builds up, and it builds up, and it's only when this starts to discharge and turn round and go out of the cranium in the opposite direction does the pressure on these veins start to decrease, and then they discharge. So this is the peak of storage in the cranium. When they discharge, the arterial starts to come back up, and so we have this beautiful relationship. And so what we have here, for the first time, is a temporal model of the changes in the arterial and the venous and the cerebrospinal fluid inside the cranium. Now, this methodology could be used in a whole load of pathologies to look at things, but it suggests very strongly that there's a strong link in the subarachnoid space between the veins, the cortical bridging veins, and the CSF. And that's extremely important. I'll talk about it later. Thank you.
Thank you, Clive. Questions, Paolo? Doesn't matter. Robert?
Very nice talk, Clive. I didn't understand in this talk where is the evidence coming that beyond the theory and this previous work that cortical bridging vein may really store the blood, because I think more work needs to be done to really, but we discussed that many times, yeah. And I really feel that if you will be able to demonstrate that there is really a respect to the extracranial venous stasis, something really related to the cortical bridging veins, that could be really extremely important pathogenetically for a number of neurodegenerative disorders. Because, for example, as I was talking before, environmental factors like Epstein-Barr virus in multiple sclerosis that clearly are involved with meningeal inflammation and cortical demyelination may really play in role with the altered venous cortical system and not the whole brain. On the other diseases like Alzheimer's disease, maybe other environmental mechanisms may be at play. And this is related to everybody. Maybe we should really study better the venous flow just in the cortex instead of studying it all around the brain.
Robert, could I maybe answer that? First of all, the next talk I'm going to bring in the Aqueductus Sylvius, which will then start to see results that are very similar to what we found before. So that seems to provide evidence. Of course, I'm supposing that that's in the cortical bridging veins because of what other people have found, and it makes sense. But this is not hypothesis. This is just straightforward signal processing of those signals. That's what that gives. If we assume that the flow in the cerebrovascular bed in the healthy young individuals is smooth. So this is evidence of itself that there is venous blood being stored, and it has this pattern. Where it's being stored, I don't know. Well, I surmise it's in the cortical bridging veins and the cortical veins, because if you remember, we found on numerous occasions when we've analysed the data, we did it and published it with the Alzheimer's, but we've seen it in other data sets, that when we see restricted venous outflow, we see increased parenchyma volume, particularly in the cortex, which we assume now is actually blood being stored in the veins. But I agree with all your other points. This is huge. There's lots to look at, which we could then bring into this. Yeah.
Thank you. One final question, Paolo.
Thank you very much, Clive, because I think that these are two really fantastic platform presentations.
Yeah.
Regarding the first, I think that is very important what you've shown, but need probably to be expanded because the internal jugular vein is not considered that it's a pulsatile vessel. So I think it's very important to analyze the change in cross-sectional area along the entire cardiac cycle.
Yeah.
Because when we breathe normally or during the apnea phase, the pulsatility of the internal jugular vein is related exactly as the CSF flow to the cardiac cycle. This, I think, that could be a good point for the future.
Well, I think it's hugely important. Yes, it is, of course, pulsatile, and really pulsatile by the respiratory action of the thoracic pump. I think it's an area that's hugely important. On a completely different subject area, I'm obviously getting more interest in exercise physiology. And one of the things I found that when you have the Valsalva maneuver, and this was looking at a completely different scenario, context, was that in fact the cerebral perfusion drops. Not only does the venous, which I'd always looked at, but it also drops on the arterial side. So the perfusion changes. So I would see no reason why, that was in a context of elite sport, I was looking at that, but I would see no difference why that might be happening on a lesser extent if the thoracic pump is inhibited in some ways. And I don't think anybody's looked at that. Kind of partial kind of Valsalva maneuver type effects, and the effect on the arterial as well as the venous.
Sorry, we're about 20 minutes late here, so.
Just to answer this point, we did reproducibility results on MRI with the change of cross-sectional area along the cardiac cycle. This is really very little change, less than 1 millimeter square in the cross-sectional area, C7 level. I don't think that cardiac cycle is affecting what the MRI machine in supine position very much. It's very negative.
All right, well, thank you very much, everyone, to the speakers. I want to point out that we're still going to take our 15-minute coffee break, and we're going to start at 10:45. We'll just have 45 minutes for lunch, and since the lunch and coffee are in the same place, it will be easy, so enjoy. Please continue the discussion there. Thank you very much.
That we don't run over, so I'd like to ask all the speakers to try and stick strictly to the time they've been allotted on the program. And then one final note for everyone here that don't forget the gala tonight. Bus is leaving from outside the Continental Hotel next door at 7 o'clock. And I'm looking for Clive, who should be back, but I think we should just get started probably. And then my name is Mike Dake from Stanford, and I am co-chairing this session with Clive Beggs, who you met in the last session. And we're going to start out with what I'm sure will be a very interesting talk on 2D and 3D analysis of vessels in the retina and the brain by Bert Promeny. Bert, welcome.
Thank you very much. Thank you very much for inviting me for this conference, and I want to especially thank Professor Mark Haki to invite me for this lecture. I don't see many people yet, but I think I should just start.
I'm afraid we're going to have to start,
Okay.
and they'll come in once they hear you speaking, but we don't want to get any more behind than we already are.
Okay.
Thank you, Bert.
I will talk about 2D and 3D analysis of vessels, and as you see, I will also talk about retinal vessels. And I'm a physicist, and my background is in computer-aided diagnosis. How can we do quantitative image analysis and visualization of especially complex images? The field is called pattern recognition or computer vision, and today we have incredibly many images, but also much more complex images. Images that are not just voxels or pixels, but we have also vectors. We even have tensors. They're high-dimensional, three-dimensional, four-dimensional, an incredible number of slices. And I want to begin, before I start talking about flow, how did we come to it, a little bit historically. We looked at diffusion tensor imaging. And what is diffusion tensor imaging? In every voxel, you make a kind of a matrix. It's called a tensor. It's this matrix. And if you do some mathematical analysis on the matrix, you find that it has eigenvectors. And these are exactly the motions of water molecules in an MRI. And we all know diffusion tensor imaging. We can do the fiber lines, the tractography in the brain by tracking the longest axis. And here you see the type of research that we do in my group. This is tractography in the brain. In every voxel, we have these little ellipsoids. You see already the ellipsoids here are connected. But when I show the longest axis connected, we first draw a line on the area we want to see, for example, the corpus callosum, and see the connectivity between the two brain halves in the white matter structure. And this is what we call streamlines. And I'm going to use the same streamlines in the flow fields that I'm going to show later. But we have programmed everything on computer game cards. These are made for specifically 3D renderings in games. They're extremely cheap and very, very powerful. There are 1,000 computers in one. And we can now beautifully see the fibers in the brain. And as you see, we have added some specularities, just like a horse in the sun. Then you can appreciate very much how is the direction. So we looked at the physics of how do you render hair. Here we have taken the orientation of the fibers in color. So X, Y, Z is red, green, blue. And you beautifully see the, let's say, the connectivity of the streamlines. But of course, we're going to look at flow. And if you look at flow, we can measure that with MRI. And I do it here for the heart aortic arch. And if you see the phase contrast MRI, you have velocity in left to right, another plane, anterior, posterior, inferior, superior. But it's difficult to view. And how can you view those things? So we looked at all kinds of ways to actually look at flow. It's a vector, so you can draw all these vectors, but it's too dense. It's far too complex. So what you do is you reduce it to get rid of all this visual clutter. I call it 4D because it's actually 3D plus time. You can also say, well, I only want to see in this little plane here, and then only the streamlines that go like here, and you can take the vena cava, you can take the aortic plane, but you have to reduce in some way what you see. Well, here we have an aneurysm in the brain, and the normal viewing is what we call the heated object scale. We go from cool to heat, but it's not appreciated very well where are the highest blood velocities, so we changed it into this scale, and now it's much better seen, appreciated that the high velocities are the lighter ones. They are just right here. But of course, you like to see it in a more animated motion, so if I see this movie, you now see how actually the blood is in a turbulent flow in this aneurysm. And we can nicely see what is how is the shape influencing this blood flow. But how does it look in the aorta? And one of my PhD students came with a brilliant idea. He said, well, if you have these streamlines, you need to actually follow them, and let's put a virtual particle here. So interactively, you can put a probe in the beginning of your aorta where you like to show seeing. And we have vertical seeds here, and each seed will follow the flow of the blood. And you see, that we have the vertex, that we have turbulent flow. And what's so nice, and I'll stop the movie if it's in the beginning, what we did is, if we added a little bit of visual illusions. If it goes faster, a particle, we make it more elliptic. If it goes faster, we make it lighter. If it goes faster, we add a little bit of these tails, and more of these tails. So just like if you look at the cartoon, you look at Tintin or something, then it also has these visual tricks. And we use these cartoon tricks to actually show the visual blood flow. Well, having this in real time on a PC, on your graphics card, you can do lots of experiments on what do you really want to see. For example, you could see, well, given the heartbeat, how are these flows starting from this point, how is it exactly going? You could look at, I don't want, let's say, I want to move a little bit around this point of where do I start? You can, with your mouse, just see how exactly is the flow moving. And we're doing now dozens of patients to see the heart valve functioning. If you have some leakage in the heart valves, you immediately see it in these turbulent flows. And of course, this is now for a big vessel because we have a lot of stream flows there, but we want to go to smaller vessels as well, and then to go to brain vessels as well. So if I stop this one, you can also do lots of other experiments where you do not look at just a small time frame, but you look at some longer time frame and you see the motion in the vertex. And here we study, let's say, the velocity profile in some planes in the middle. And here we have a look at the velocity profiles more as a kind of a tube. And as you see, you can now see the exact shape of the velocity profile and also model this with biomechanical flow models. Let's go to the microvasculature, also of the brain, but then looking in the retina. And the retina is an extremely accessible way to look at microvasculature. You take easily 12 megapixels images with a fundus camera, and what you see is everything from angiogenesis, microbleeds, all kinds of vessel dilations, aneurysms, and of course you can do some improvement of the contrast to see this better. And what I'm talking in the second part of this lecture is about how to quantify all the things that we see here. So microbleeds, you do some enhancement and it clearly can be seen, and we develop software to automatically detect them, count them, quantify them. And of course, I'd like to collaborate with Professor Haki much further on relating the optical measuring microbleeds with the MRI measuring of microbleeds. And we have an incredible detail. You can nicely see what are the veins, what are the vessels, to incredible branching patterns. We have the fovea here, that's a vessel-free region. And we have been asked to help to detect early detection of diabetes by the Chinese government. And as you all know, diabetes is incredibly epidemic, and in China it's even far more. There are genetic reasons, probably by big famines in the past. It's now estimated that close to 10% of the Chinese population has diabetes. And that's an incredible burden for healthcare system. And it's over 90 million people now. So there was a need for cost-effective analysis methods for large to huge scale screening. And if you look at diabetic retinopathy, one of the earliest signs for all kinds of changes, it's a major reason for blindness. You can see all kinds of leakage, of course, the microbleeds, cotton wool spots, exudates, optic disc changes. Finally, we do not only look at diabetic retinopathy, but all kinds of other eye diseases like glaucoma, age-related macular degeneration. And we're going to look at the morphological changes of the blood vessels if they lose their blood-brain barrier and if they change in, let's say, vessel wall thickness and so on, but then on the microvascular level. And to quantify this, because humans are known to not see well all these changes. And what we now are in, I'm a project leader of a large-scale screening project in Liaoning, that's a province in China, and we go screen 24 million people. That's a lot. And we're setting up a large collaboration with He, that's a conglomerate of 11 big eye hospitals. If we have it in the hospitals running, we go to 200 healthcare centers, and then we have buses now, 4 buses equipped with cameras who can even go to the rural areas. So we're going to collect an incredible amount of these images and do big data, quantified image analysis. And we are currently in a diabetes department, we have a room, it's a little bit similar like the Maastricht study, where we have a very deep phenotyping study. We do exactly the same here. And so far, the last 2 months, we have been able to record already 1,100 patients fully with high-resolution imaging, and we record the full diabetic metadata with it. So we have all the blood sample, the urine samples, and so on, and the glucose fasting rates, etc., from these patients. So what is the main idea? That we're going to detect many geometric, fully automatic geometric biomarkers from the images, and it's known that there is a relation if you couple those and you put them in a higher dimensional, let's say, pattern recognition pattern, that diabetes is related to those two, AVR, tortuosity, glaucoma is more related to those, hypertension and cardiovascular diseases to those. So finally, we like to make a one-stop shop if a patient comes in and we have this retinal analysis, that we can have a prediction of the probability that we have one of these cases. So how do we do this? And of course, in the future, we like to see more relations with, as we discussed many times earlier this morning, with Alzheimer, stroke prediction, and diabetic retinopathy prediction to occur for people who don't have it. The structure is, we have groups in Eindhoven, where I come from, fully focusing on vasculature analysis. We have groups in China, fully focusing on background tissue analysis, that means microbleeds. The whole team is now over 25 people. We have major funding from the Chinese government and the Dutch government, and several companies who join us. And we have a special group on optic nerve head detection. So we detect many things: curvature, caliber, bifurcations. What is the bifurcation angle? Normally it should be a straight way to go directly to the area you want to bring the oxygen. How many lesions? And we group the patients in healthy, R1, R2, and R3, and this is the International Ophthalmology grouping of diabetes patients, or diabetic retinopathy patients. Let's cover a couple of detections that we do. Microbleeds, of course, fully automatically detected. We looked at what's a good camera to use. We looked at the same person, actually a dozen of the same person in 6 different cameras. All cameras have different features, but it turns out that laser scan cameras of today, they have a green laser, which is perfectly tuned to the absorption of hemoglobin. So we get a very nice contrast with a laser scan, and that's even a lower light damage, light burden for the patient. So this iOptics was chosen as the best quality to price-quality relation. But if we do all this pattern recognition on these images to find the microbleeds, to find the angiogenesis, to find the vessels, the best pattern recognition machine is our brain, our visual system. So in my group, we do a lot of investigations. How is this visual system actually working? And what we see is that it has lots of filters on board who take measures from the images. It takes actually derivatives. It finds edges, it finds curvature, and so on. And what they found in Israel some time ago, if you show a mouse some oriented lines, indicated by the green lines here, you see on the cortex small islands of orientation patterns, and these are called the cortical columns. And we now perfectly understand the mathematics of these cortical columns. Here you see what happens. It's a very strange but incredibly well-organized cortex that we see here. So what is actually happening here? These columns turn out to be very nicely stack of patterns of orientation filters. And if we have these orientation filters here, that actually we see that one such a cortical filter is a complete computer for 1 pixel in the visual machine. And we have millions or thousands of these visual cortex, of these cortical columns. So what happens in every pixel, we have all these orientation filters. They look at the world like this, and we make stacks of all these. One image is not only one image now, but a whole set of images, each time seen by a a strange filter. But now we can do many things that we couldn't do before. If we have, for example, vessels that cross, they are now in different planes in this new space. We can much better take the noise out by taking elliptic filters and so on. So it's a big advantage, but you get more computing power. That's exactly what happens. A quarter of our brain is for vision, and there's an incredible amount of filters, and that's doing just this. And we have multi-orientation, but also multi-scale, and multi-velocity, and multi-disparity. So it's a wide range of filters. And this happens to solve many problems that we had before. So if you have a pretty, let's say, crossing, noisy pattern, you can nicely clean it up. And that's exactly what we do with our blood vessel analysis. For example, here we took the optic disc detection. You want to find out what is the circular orientation, the concentric patterns. Well, this is the density of the concentric patterns. You have the radial patterns going out, that is this. And together, you nicely find the optic disc very easily with this multi-orientation pattern. It's a little bit from system theory, but our method was capable of finding in 1,200 fundus images with 100% sensitivity and specificity the optic disc. We also defined nicely tracking algorithms. You see it here very slowly, but we track carefully every blood vessel, these thousands of blood vessels in the high-resolution retina. You see, even if it is crossing vessels, we can nicely see how well the algorithm detects. Even if vessels are very close together, we can nicely now find them. And this means we have the full quantitative analysis of these vessels. We can see incredibly small thinnings, widenings, aneurysms, small stenosis of these microvessels, and actually brain microvasculature. So we have a lot of, you can study one vessel at a time with all the connectivity. You can see how far has it been from the origin when it enters the eye. You can indicate the tortuosity, and of course you see that there is a lot of relation between vessels get more curved if they get starting weaker. So you indicate with the color the tortuosity, and And here we did a ranking of all these patterns that we collected. So we have 17 biomarkers that we quantitatively took from these images, and we ranked them how predictive or what's the classification power for diabetic retinopathy. And the first 6 were by far the most classifying, so those we will take in this big screening study. We can detect bifurcations very easily and fully automatically. And this is the trick. It should be fully automatic and quantitative. We have now access to what is the average segment length, what is the branching angle, but then for hundreds to thousands of these patterns in one image, but we have also thousands of these images. This happens to be a filter that just was standing in the pixel and then looked around for 360 degrees, and you just measure how many maxima do you see. If you see 3 maxima, well, of course, you are in a bifurcation. If you see 4, you have the red ones here, we have a crossing. So we can find all these nice biomarkers, and if you do a registration of images, you use these landmark points. Here we see the best curvature detection so far published. We have compared this to 6 other curvature measures, and this is using this multi-orientation scale. And here you see the coloring of the high curvature. And here we took 1,200 images from a group of patients with diabetic retinopathy, healthy patients, R1, R2, and R3, and you clearly see the increase of curvature with the progression of the disease. And this is the mean of the curvature, and this is the standard deviation of the curvature, which shows the same pattern. What we like to do is, of course, and we don't have that yet, that is to look in incredible detail to these retina. It's a pretty expensive system, and we focus on the more cheaper system, but that is look through this terrible lens of the eye. You cannot look with a microscope in the eye to see really the small things, but you see the lens is quite carefully organized, but it is a tricky lens. But we learned from astronomy, if you look at a star, and also the light comes in and it is going through all kinds of different temperatures and different velocities, a wavelength will be quite irregular, but you can measure the wavefront and make it regular. So you have a wavefront here, and then you use a mirror to make it regular. So you have a deformable mirror, and you have a perfectly corrected wavefront. Well, that's called adaptive optics, and we now just released a grant application to get a system like that. It's used to be a big optical table, but it can be now much smaller. And what we can do then is look at incredible detail at the microvasculature. You see these individual rods and cones here. If we go a little deeper, you see the red blood cells flowing. And we can now study on a single cell level the retina. So let's make a summary. In my group, we have done a lot of analysis of, let's say, visualization of very complex structures. In this case, the structure of the white matter in terms of how can we find the myelinated fibers in the white structure. We used all that for flow visualization. Let's look one more time at the particle flow and appreciate the vertices and all kinds of flow measures that we can do. We have endless of these examples. The main focus is on quantitative microvascular analysis. As I said, this is a big project with the Chinese government. We got 4 million or 3.6 million yuan funding last year, also funding by the European Diabetes Foundation. It is a cheap method, so that's because if you do 24 million, you cannot use MRI or OCT, which is of course available, but we needed to go, what can we do from these high-resolution images? Well, we can do quite a lot. So it is a deep phenotyping study on geometric properties, AV ratio, widenings, curvature on these blood vessels. And what we use is pretty fancy computing. This is what we call differential geometry, learning from the brain. I wrote several books on this topic on how can we mimic this brain-inspired computing. And that is actually learned from modern optical methods of the visual system. So it's actually a little bit vision for vision, learning from vision to prevent visual loss. So I end with an acknowledgement with the team that we have. We have several. This is the doctor leading this group of eye hospitals in Liaoning, Professor Weige. And we have the teams in the groups that you see here. And with that, I'd like to thank you for listening.
Thank you very much, Professor Romani. It's great to see vector fields as far as I'm concerned. Can I just ask one little question?
Of course.
I noticed that the blood vessels you had there were actually quite rigid. They didn't move. Did you look at the changes in the compliance of those and the shear stresses that your flow? Are you able to look at that? Because that's something we're extremely interested in.
We're currently doing that, but that's a matter of how well can the MRI examination be done. We do this with the UCL in London.
Yeah.
We can now scan about 25 images, 3D images per second. So in principle, we have fully 4D data, 3D 150 cube, and then 25 images per second. So what you say is indeed, it is accessible, but we haven't done that yet. We have focused on the visualization and all the tricks with that, and the next phase will be what happens during the whole heartbeat, all the different phases during the systole, diastole.
Thank you. Robert, yes.
Wow, this is amazing. I mean, for some reason in our original study of CCSVI with 1,000 people that I presented, we took the high-resolution photos of the retina. And these images are just sitting there for the last 5 years. Nobody ever looked at them. So, I mean, it would be really amazing to see if you can analyze those, whether there is some connection with the CCSVI and with the venustasis and all the other MRI markers. But I wanted to ask you really another question. Respect to those parameters that you showed, do you have an idea? I mean, you showed what's the most predictive for diabetic retinopathy, but what are other parameters that are most predictive for, let's say, brain volume changes or cortical atrophy or having lesions in the brain? Do you have any data on that?
It is particularly part of this study. It is a deep phenotyping study. When we set up this, we said, let's focus first on what is capable of doing, and let's first focus on diabetic retinopathy. It was the major question to find that early, so we studied microbleeds and these curvature changes. But we quickly said it should be a one-stop shop, that we if a patient comes in and we know nothing, that we can see what can we see in these images. So it will be a quite elaborate study. We have now only 1,100, but we actually just started. But soon we will have thousands and 10,000s and probably 100,000s of these images, including the, let's say, the diagnostic data from these patients. So it will be quite a big study. We start collaborating with the, now only for ophthalmology, with the Maastricht study in Maastricht. We have now access, this room that you see here is in the middle of the diabetes department in Shenzhen Hospital in Shenyang, which is quite extraordinary. You never get space for this kind of experiments, but there we will do this deep phenotyping study, as I said before. So a lot is still not known, but it has this high perspective, exactly as you said. So it turns out that the quantitative analysis is relatively easy to do. The resolutions are with such incredible resolution. It's just a normal, regular digital camera, and you have 12 megapixels in a second at no cost. So it is a really nice way of looking at these images. And of course, we we have the Spectralis camera too, and of course we are now looking. If you start to do 400 of these cameras, you have to look a little bit at the costs of the cameras as well. So you have to look at what is the best benefit. And then these laser scan cameras turn out to have an incredible contrast just because of their physics. It's a green laser, and that's just the absorbing wavelength for the hemoglobin, so desoxy and oxygenated. You can see very nice the differences, the early microbleeds.
So we should present next year our collaboration.
I think that there are many combinations possible indeed. We do, let's say, morphological changes, geometry, by the computer, and of course we need to relate that to the many things you mentioned.
I think we're going to have to finish there because time is passing on. So we'll just let the computers be changed over. The next speaker needs no introduction. It's Paolo Zamboni, and he's going to be talking on a novel sonographic method for looking at the internal jugular vein pulses, which really follows on very nicely with the stuff that we heard this morning. So I'll just let them get set up and they can head off.
Posso andare avanti con la barra, questa qui? Okay. Ladies and gentlemen, good morning. Today I'll speak about a novel sonographic method for jugular vein pulse assessment. I do not have relevant conflict of interest. But what is jugular vein pulse? Jugular vein pulse is something that is very known in medicine. It's the movement of expansion of the jugular veins due to changes in pressure related to the cardiac cycle. It provides valuable information about cardiac hemodynamics and especially the heart filling. And some JVP wave patterns are really pathognomonic of cardiac disease. It also provides an indirect estimate of the central venous pressure and is useful for diagnosis and prognosis of many heart disease.
A and V being crests, registering high pressure, X and Y being troughs or periods of low pressure. The A wave corresponds to right atrial systole. A fifth positive wave, C, may interrupt the X descent. The X descent begins with atrial relaxation and is augmented during the earlier part of ventricular systole by displacement of the floor of the atrioventricular septum towards the apex of the heart, creating a negative pressure within the atria. The venous pressure rises later during ventricular systole to form the V wave, because at this time outflow from the atria is temporarily obstructed. The Y descent, or the downslope of V, begins as soon as the tricuspid valve opens, when right atrial and ventricular pressures equalize rapidly and fall together to the trough Y, after which they rise again before the onset of the next atrial contraction.
The jugular vein pulse is the best prognostic index in chronic heart failure, according to to the New England Journal of Medicine. But JVP is one and probably the most challenging part of a medical physical assessment. Is not more performed, and also the assessment of a wave is particularly complex. There are succedaneous ultrasonographic methods that are developed, but unfortunately, with very low diagnostic accuracy. You may see clearly the pulsation of the jugular vein. The height of the column between the right atrium and the pulsation give an estimate of the central venous pressure. Assessment of the waves is particularly complex with polygraph that are capable to give contemporaneously, and this is the goal, the ECG traits, the carotid arterial distension, as well as the jugular venous pulse. JVP is synchronized with everything happen in the heart, particularly with electrocardiogram traces, because the A wave is synchronized with the P of the electrocardiogram and the T with the Y. Also, the Y is synchronized with the open of the tricuspidalic valve, because it attracts the venous flow from the neck to the right atrium. Jugular venous pulse is a sequence of variation of the CSA along the cardiac cycle. When I began to investigate the jugular vein, the number of frames that I used was so small that I was not capable to catch the variation of the CSA of the jugular valve. But if you are capable to increase the number of frames, you may see the phenomenon of the pulsatility. We hypothesized to measure the CSA and perimeter of the internal jugular vein simply from a real-time B-mode movie in order to obtain the sequence of their variation. And the sequence of CSA values should represent the jugular venous pulse curve. This is a simple example. We are exactly between J2 and J1, and you may see, as usual, the pulsation of the jugular vein and of the carotid artery. These movies were analyzed. This is a publication in the latest issue of the Ultrasound Medicine and Biology journal. And we propose an ultrasonographic method of post-analysis, post-processing, in order to obtain both the arterial distension of the carotid as well as the jugular venous pulse. In this paper, we manually traced the internal jugular vein contour from a B-mode movie of about 5 seconds. In 5 seconds, we have about 200 frames. And alternatively, the trace comes from a semi-automatic algorithm and software developed in Home. A manual and algorithm trace is highly correlated with 0.9, and the two methods show a sensitivity of 95%, specificity 85%, accuracy 90%. This is very important because, of course, to trace 200 elliptical shape is a time-consuming maneuver. But with this algorithm, in a few seconds, you may obtain exactly this. And you may see that you have nicely the curve with A, C, X, V, and Y for each cardiac cycle. It's very important that the correlation between the cross-sectional area and the perimeter is very high. And this permits us to affirm that the internal jugular vein is, we permit to measure the distensibility, and the distensibility may permit us to measure other hemodynamic parameters. You may see the arterial distension, and the two signals are perfectly in phase and synchronized. To explore the brain-heart connection, we need of the carotid pulse, of the venous pulse, and the ECG trace. And the lacking element is what has been shown today by Clive Becks in the CSF. You may see that we may have, from an ultrasound machine, the synchronism of the internal jugular vein, heart, and carotid. We need just to add the CSF flow signal. CSF flow is the lacking part of the heart-brain connection, but I think that all this needs to be synchronized, and we may see really a new scenario. A new scenario is exactly if you should have an arterial disease as well as a venous disease, or the combination of the two. Also, the pulsatility of the internal jugular vein changed completely the perspective in order to measure velocity, flow, and other hemodynamic parameters. Because the Poiseuille assumption is not true for the internal jugular vein. The flow is time average velocity for just one value of cross-sectional area. This is not true, because we have to apply the Womersley method that you may see on the right, but take into account the CSA variation because it's a pulsatile vessel. Pulsatile vessel, the flow is calculated with this different approach. We try to compare the two methods because this gives really clinical and diagnostic implication. Is there a systemic error in our brain-venous outflow assessment? I think yes. The CSA of an internal jugular vein, as I showed you, significantly changes along the cardiac cycle. The flow of internal jugular vein is a pulsed flow, so characterized by a sequence of changes, not just one value of cross-sectional area. But current ultrasound Doppler flow assessment apply a Poiseuille method that maybe is not right because it's just one single value of CSA. And even the climate objective magnetic resonance flow assessment does not take into account the real CSA variation. And so I think that our actual measurements are really affected. It does not respect the truth. And we need probably to change something and to compare the signal of the vein not just to one CSA value, but to synchronize the JVP pulse with all the other signal at the intracranial level. For example, you may see two cases with time average velocity compared with comparing the normal method, Q is equal to one value of CSA for time average velocity, respect to the Womersley method, the pulsatile method, the jugular vein pulse. You may see that the first curve are practically not significantly different, but for the subject 2, certainly we may have differences between the two, showing that the flow assessment based on the time average velocity is certainly different. Some preliminary results of ultrasound JVP application is actually in the mission in the International Space Station called Future 42, where we trained the astronauts, and especially the Italian astronaut Cristoforetti, to an auto-echography in order to see if you are capable to catch the different brain drainage in the absence of gravity respect to the heart. And you may see unbelievable results if you may compare the upper trace, the top trace, respect to the same cosmonaut after 8 days of permanence in the space, the green trace. You may see that there is an increased heart rate, and the amplitude of the negative and positive wave are reduced. And this means reduced compliance, and reduced compliance means reduced venous return from the brain in that condition, and less cardiac filling. So this is very important because this is a methodology of telemedicine. So this is someone that is simply put the probe of the ultrasound in the neck and transmit from the space in a post-processing analysis center, and we are capable to see what happens. But this is really a window on the heart and on the brain. Also, we compared cerebral venous return in healthy controls versus patients with blocked brain venous outflow in the jugular. You know that the blocked venous outflow by Doppler is a very controversial issue because we have paper confirming and paper not confirming the Doppler absence of Doppler trace. So you see two typical cases, and you may see really that the sequence of the cross-sectional area of the pulse in CSSVI condition is really different with respect to the normal one. Especially, you may see that the Y negative is practically wave is practically equal to the A positive, meaning blocked flow, because the negative wave, the lower negative wave is practically equal to the highest positive wave. This is blocked flow. But this really is reproducible because it's a simple B-mode real-time movie and post-processing by an algorithm. So operator, no operator dependency. And this proves that the blocked flow in the internal jugular vein in CSSVI condition really exists. This is very interesting because in another case with two individuals, the top trace is one jugular vein, the left with blocked flow, and the bottom trace is the same individual with a normal jugular flow in the right internal jugular vein. So same heart, same brain, but CSSVI in one of the two, and you may see how long are the X and Y trap, because there is no cardiac filling when the tricuspidalic valve is open, because it's blocked and is trapped. And this is very clear. Also, you may see again the A and Y that practically are have the same amplitude of the wave. So this is a promising study, is under progress. I think that this may help us in establish a good relationship between heart and brain. JVP is a challenging but pivotal cardiovascular parameter. It can be now derived in post-processing by short, non-invasive B-mode clip synchronized with electrocardiogram and carotid distancing wave. Ultrasound JVP allows a more precise flow quantification with the Womersley theorem, and also OS JVP may allow a more simple, rapid, and reproducible assessment of extracranial venous outflow with less operator dependency. Thank you very much for your attention.
Thank you, Paolo, for that absolutely excellent presentation. Have we any questions from the floor?
Thank you, Paolo, for your presentation. It's very interesting. And we are now involved in the evaluation or in the flow quantification of the cerebral blood flow, outflow. And I think that we have to change the method to measure the outflow and to change the cross-section area evaluation, because the cross-section area can change over time, and we have the necessity to have a system for tracking in real time the modulation of the cross-section area. And this is not a problem, I think, because we have also software for this, but the problem is to change the sample volume, because if you change the cross-section area, you can change also the profile, flow profile, so the velocity change over time, and you have to change and modulate the sample volume on this change.
Yes, Marcello, this is true if you should use the current method. But with this method, simply with perimeter and the cross-sectional area variation, no sample, no other kind of Doppler. I do not use Doppler at all. Because of the distanceability, I may calculate velocity, flow rate, and pressure gradient. So we have performed some experiments putting a manometer in the jugular vein at 2 different levels, and we are capable to catch the different pressure. It's not invasive.
At the back. Where's the back?
Hi. How do you account for...
This is the Chinese gong.
How do you account for the valve? If the valve is not working properly, it will affect your waveform. So therefore, how do you account for the valve in your theory here?
Yes, thank you very much. In the cases that I showed you, Karen, the valve was not working properly. And the blocked flow was the effect of not mobile valve leaflets. However, whatever is the cause of the blocked flow or compression or not working valve or both combination, you are capable, if you have a lumen, to measure all these parameters. 5 seconds.
Any other questions?
How many hertz has the probe?
The probe is a normal probe. The difference is really the resolution of the equipment. If you should have a very good resolution equipment of ultrasound, you are capable to have more and more frame, and so you may have a more clear curve, a more clear variation of the CSA, and also your measurement of the hemodynamic parameter without Doppler can be really more reliable, I think.
Paolo, may I ask a question? I was really intrigued with your astronaut, the change when they were out after being in space. I understand that astronauts suffer from orthostatic hypotension a lot. Would that be a characteristic shape that you would see in patients who maybe have POTS or orthostatic hypotension? Have you thought about that or exploring that area?
I think that our proposal was accepted by the national agency American in this mission. Maybe they are very happy of this because we are capable to have all this information with simple equipment. Because of course in the space you do not have MRI, CT scan or whatever. So this is a very simple and very interesting for you. This correlates very well with the plethysmographic method. So the astronaut have also color for plethysmography.
Yeah.
So you may have volume variation that is synchronized with the JVP and carotid distension. So the signal can be seen very well, and the difference in volume of blood that return to the heart is very clearly visible. So I think that the correlation with the orthostatic intolerance when they return to the heart maybe could be explained with this.
It might be very useful in that context anyway.
Yeah. We hope so.
Yeah. Sorry.
Robert Zivaninov this morning showed us that hypertension is more prevalent in patients with multiple sclerosis. Do you think that hypertension could modify diastolic function and can justify a modification in the jugular pulse?
I think yes. I think that probably by stratification, we are just at the beginning of this work, but with stratification of the subjects, we are capable to see the different combination. Also, I think that hypertension, in case of hampered venous outflow from the brain, is probably more and more aggressive for microcirculation. I think this for dementia, vascular dementia and Alzheimer's disease is an important factor because you demonstrated that with aging, the increase of the venous outflow problem is increased. So I think that this could be a good perspective.
Great. Thank you very much, Paolo. That was very stimulating, a lot of good questions. And now, yes, thank you. And now Clive is going to come back and, as promised, talk about factors influencing aqueductal cerebrospinal fluid motion in healthy individuals. Clive.
Right. Well, I'm going to now build on the work that I showed earlier on, and the models that I've showed. This, again, is work that I've done with Marcello Lugana, and it's actually very, very new work. We really completed the results only in the last week or two, so they're brand spanking new. But they're very, very interesting because I'd like to thank the team as well and acknowledge their participation in this. As I alluded to, what we see in various pathologies and also see in individuals who've got constricted venous outflow is this increased cerebral pulsatility in the aqueduct of Sylvius. The CSF is becoming, the amplitude is becoming greater. And I've been interested in this for a long time. And it was only recently that I finalized the model for the volumetric temporal model of the volume changes of fluids in the brain. And so I applied it to this work here. We've been using other methodologies before, and I'm hoping that you will see some very interesting results today. I was really blown away by the results that we got. And so I hope to explain the motion of the aqueduct of Sylvius, the motion of the CSF in there, which then in healthy individuals relates very much to the motion of the lateral ventricles. So it's very interesting stuff. So just going back, we all know that there's this Windkessel mechanism in the brain that regulates the flow. And so it takes out the pulsatility in healthy young individuals and ensures that the flow through the cerebral vascular bed, through the capillaries, is smooth. Now, of course, a number of speakers have alluded to this over the day, and the point is that as you get older, your compliance of your vessels changes, the structure of the vessel walls changes, and so they become less compliant. So this Vin-Kessel mechanism becomes less good at displacing, taking the pulse out of the arterial, less good at displacing cerebrospinal fluid, and so you get more pulsatility through this vascular bed. And this pulsatility is extremely interesting because if you think about it from a fluids point of view, you've only got two options. Either you can have the vessels expand, which I'm sure they do to a certain extent, but that will displace something else, increase the shear forces on the tight junctions, or not the shear forces, but increase the forces on those. Or you can have pulsar flow and increase shear forces on the endothelia, which we know everywhere else changes the behavior of the endothelia. So it's very interesting, this pulsatility and this smoothness here. And of course, this pulse comes back into the venous side. And this is what I'm really interested in, is what's happening here. So to recap, we know that if we start to have constricted venous outflow, this pulse in the aqueductus sylvius the amplitude becomes greater. So what's so special about this area here? Well, I think the reason it's useful is because it's right at the heart of the brain. It's a small vessel that is fairly controlled, and it controls not only the pulsatility of the flow in the ventricles and through these third and fourth ventricle, so it accounts for the pulsatility, but it also accounts for the bulk flow from the choroid plexus around the system. There's a slow bulk flow through into the arachnoid villi and then into the sagittal sinus. So this captures all these things. So it's quite a useful place to view. Now, I wish there was more data out like this, but time series data where we've got the really the flow in the aqueductus sylvius versus the dilation of the ventricles. And here's work that was done in a very, very good paper by Zhu some years ago. And they looked at the basal artery pulse, the area of the lateral ventricles, third ventricle, and the aqueductus sylvius. And so what I did was I just simply did a correlation between these two here, took the data off their particular graph. And here you see the correlation. Actually, it's kind of a cyclical motion, but the R value, the correlation value, it's an inverse relationship, and it's up near 0.9. So there's a strong correlation between what's going on in the lateral ventricles and what's going on in the aqueducts of sylvius, which is what you'd expect in healthy individuals, I hasten to add. I haven't got the same data for MS patients or other patients with pathologies, but what we do notice is that things change in the aqueduct of sylvius to do with pathology. We know in the MS patients that two things happen. The flow becomes more pulsatile, particularly in the positive direction, up towards the ventricles, the lateral ventricles. We're getting more flow in that direction in the MS patients. I just quantified that, 45% more flow in this case. And the bulk flow of the CSF from the choroid plexus down the aqueduct of sylvius, presumably to the arachnoid villi, is reducing. So that tells me we've got some form of venous hypertension somewhere in the system. But if you look at normal pressure hydrocephalus, we also get similar type of shape. I haven't done work on this, but this is from someone else's work. But we notice there, and it's been documented by many researchers, that they get increased pulsatility again in the aqueduct of sylvius. And Robert alluded to it earlier on today. We presented this work last year, and it's just going to come out in the Journal of Neuroimaging. We have since found and showed that we get early stage white matter changes, what we call dirty appearing white matter changes, they increase in normal healthy individuals with increased pulsatility in the aqueductus sylvius, which we think is extremely important because there are increased shear forces involved in there. And I personally am extremely interested to look at ventricular reflux as well through the ependymal wall of the lateral ventricles, because I think that is very, very interesting if it's occurring to white matter hyperintensities, in the periventricular regions. But that's for another day. So we have this mystery. What's going on with the aqueductus sylvius? It's poorly understood, the motion of that. Several people have had theories, but I haven't got time to go into those. Notably, Gretz did quite a bit of work on this. But we do know that it seems to reflect pathology. And this is me as an engineer preaching to you lot. Basically, I don't see there's any point. If you want to if you have a broken machine, you better find out how that machine works in the first place before you try and mend it. And I think you understand what I'm trying to get there. We have a tendency to look at pathologies, see patients with pathologies, and we don't understand the underlying physiology. So this is what I'm trying to do here. So again, Marcella, in this case, we got 12 young healthy adults, and we did both the C2, C3 level, and also the aqueductus sylvius. And so we did an MRI slice through here, and also through the aqueductus sylvius. I'm not an MRI guy, so I won't go into that. What we found, these are the results that we found in terms of the flow. They look realistic to me because what we saw was that the flow was greater in the aqueductus sylvius in the caudal direction, down towards the spine, than in the direction back up towards the lateral ventricles, indicating that we had a bulk flow in that direction. And these were the stroke volumes that we calculated through the foramen magnum, and this was through at the aqueduct level. So, of course, here are the extracranial flows and the flow of the aqueductus sylvius, which we've multiplied 10 times so you can see it. And the question is, can we explain what's actually going on here? I've talked about all the others. So the other thing I want to point out is that we saw the peaks in the venous peaks and the foramen magnum. They did exactly as we'd expect. We saw the arterial peak first, the flow of the CSF through the foramen magnum in the caudal direction next, followed sometime later by the venous peak. So we see that they're doing we've got confidence that they're doing what we would expect. The first approach that we did, this was really before I developed the volumetric model, was that I just did a simple correlation between the flows. And the thing was that the straightforward correlation, we found a very, very strong flow between the venous outflow and the aqueductal pulse. So there's an indication that the venous may be influential in this whole kind of machine that's going on there. But of course, there are time lags involved, and some of the other signals might be even closer. And actually, when you do cross-correlation to look at the time lags, we see that actually the strongest correlation was with the cerebrospinal fluid coming back in the spine at the C2 level, followed by the venous correlation. But there was a considerable lag between the one at the C2 level compared with the venous pulse. So that indicates that is very much closer and is probably the one that's governing the behavior of this. Now, again, I stress that we are dealing here with incompressible fluids. And this is a cranium that's completely full. There's no gaseous material in there, so nothing should be compressible. And all the studies that have been done on brain parenchymal matter in labs to look at the biomechanical properties suggest that there may be a tiny bit of compressibility about them, but to all intensive purposes, they're incompressible. So if one vessel or one compartment in the brain anywhere expands, its volume must expand, something else must expand. Just as if you put your foot on the brake of your car, it's almost like an iron rod. The the brakes, the pressure's applied to the brakes, the fluid applies the pressure, and hopefully you stop. The same thing is going on. We must always remember that. So there should be no time lag, or very little time lag. Again, I've explained the model this morning, so I don't need to go into that. Let's concentrate on what we actually found. So here's the signals, which, remember, what we're trying to do is understand this. And there is the volumetric model. Now, you'll notice, the sharp-eyed ones of you, I slightly changed this. This morning, I had these pulses for the CSF and the aqueduct around a 0, going positive and negative. What I've done here is I've reflected the changes, the relative changes in the cranium or in the lateral ventricles, or the third ventricle, probably more precisely. So these are the minimum, and that's the maximum volume, maximum volume. I explained this morning what went on. As the returning CSF comes into the cranium, it starts to push out the arterial blood into the capillary bed, the stored arterial blood. So that starts to reduce and drop down to a minimum in diastole. This builds up. And of course, then it starts to impinge on the veins. And as they build up, and blood is somewhere stored in the cranium. I'm suggesting in the cortical bridging veins and the cortical veins. Their volume is expanding. Only after the CSF starts to leave the cranium and that volume starts to decrease and the arterial starts to increase, does the venous then get expelled from the cranium. And the flow starts to increase outside the cranium as that decreases. And here we have the pulse in the aqueduct following that. And now it doesn't look so well correlated, but if you actually correlate it and scale it, you find that this follows after that, implying that that's the thing that's governing this, and the correlation is incredibly close. There you are. That's scaled to it. Now, scaling doesn't make any difference to the correlation. It's just for visual effects for you. Now, that is almost a near-perfect fit. That tells me from this aggregated data that there is a near-perfect relationship between the pulse as these veins expand, as the volumetric veins expand. So, now I must come back to this. What's happening is as that arterial blood is coming into the subarachnoid space, we're finding the vessels in the subarachnoid space, the veins, are increasing in volume. The parenchyma may also be increasing in volume because the cortical veins are engorging as well. But basically, that decreases the amount of space for the cerebrospinal fluid. And remember, these are incompressible fluids. So then, at a point later on, it starts to open up the aqueduct of Sylvius, inflating the lateral ventricles, right? If it goes up, that's the fluid going up there. Only after that space starts to decrease can this start to come down. So you get that breathing effect on those ventricles. The other thing that's really crucial is, well, we'll talk about it in a minute. I'll come back to it after I've showed some more things. So this is an incredibly tight correlation. I'll leave that. But I wanted to know, really, every machine, that's just aggregated data. It should work on every patient, no matter what the patterns are. So we've got 12 subjects here, so I just took 2 to illustrate the point here. And here's one that kind of is pretty close to the aggregated data, and you can see it follows the patterns we would expect, and a bit more pulsatile in the aqueduct here, and a little less pulsatile in the cerebrospinal fluid at the foramen magnum, or the C2 level. And when you see the lines here, obviously no error bars because this is only one patient. The machine should work like any other machine, so these should have the same characteristics. What we see, there's a rather unusual increase here, which is a slight slant to this, but again, we've only developed the methodology, so we haven't applied to this anyone with pathology, so we don't know how these things characterize. But it's interesting, but we still see the same thing generally. That goes to a dip when that goes to a peak. It's more or less the same time in this case, and then the aqueductus sylvius follows on afterwards. And when you actually scale the aqueductus sylvius and the venous, you see again a very high correlation and a slight lag here, but essentially it's suggesting very strongly that this is driving that. But of course this is being driven by the returning CSF. So everything's related, but it's saying the veins are incredibly important to this motion of the ventricles. Now we take a patient who I considered was atypical of the cohort, but was in the aggregated data. Now this patient has an unusual pattern, if you compare it with the previous one, where these dip down at the same point here, and there was not that much space between here and here. They've got a delay here. Now, the thing I've got to say is, the point is, we're not working out the volumes. This is not manufactured from this on the arterial, from the other signals, as I do in another model. This is pure signal processing. So these are the measured signals. So in theory, if this machine's working for this person, no matter what it's doing, it should relate in some way exactly the same way. So this rather strange pattern, as far as we know, this person hasn't got any pathology at all, but it'd be interesting to look at the pathologies. When you look at this inside, you see some very interesting things. This particular person, you see the same pattern, but here there's a much greater delay between the veins of what's going on there. But again, we see the same signal. The correlation between the venous and the aqueductal pulse matches again. So this is very strong evidence that it's the venous blood being retained that is driving the flow in the aqueductus sylvius and the lateral ventricle movement in healthy individuals. But it now gives us the point to look at pathologies. We haven't looked at any pathologies here, but we have a chance to look at those pathologies. Because what it's saying is that there should be a relationship between the venous blood trapped somewhere in the brain, I assume in this area here. These then become incredibly important, because if you think about it, when the cerebrospinal fluid is returning from the back, you've got a half a meter or so of column of water, essentially, which is moving. So it's got some inertia. And these are actually acting as shock absorbers, because they're the only part of the brain that is compliant. Because the rest of it, there's no compliance in the system, in theory anyway. And we know that if we basically compress the internal jugular veins, you get a buildup of blood pooling in the veins in the cranium. And the work that I've done with Robert shows that as well. So essentially, if we have constricted outflow here, then we're starting to limit the functional compliance of these veins, the bridging veins, and these are the shock absorber for the whole system. So if these can't void, if we can't get free egress out of there, then they become rigid or they become semi-rigid, and that is going to have an effect. And of course, as we see, that will tend to push the cerebrospinal fluid up into these ventricles. And hence you get this relationship. So now we have demonstrated and shown what's going on and how crucially the relationship between this and the cerebrospinal fluid pulse. And as we demonstrated in our other papers, that seems to be related to white matter changes. But the thing I want to look at now is to look at the MS patients and other patients, because there should be a relationship between this and the area and behavior, temporal behavior of the lateral ventricles. If we see that breaking down in patients with MS, and I've got other data which I'm sure I've looked at in the past, not temporal data, but cross-sectional data, then that would be strongly indicative of ventricular reflux occurring, which may be a clue to what might be happening in the paraventricular region, especially with hyperintensities. But again, that's for another day. Yeah. So I think we finished there. Thank you.
Thank you, Clive. Do we have questions from the floor? We're clicking along at a pretty good clip here on time. Anyone questions for Clive? Okay, well, let's move forward then. And because we're going to have to pick up some time. Thank you, Clive.
Thank you, Mr. Chairman. First of all, I wish to thank the organizers for the opportunity that they gave me to have this talk today. And I will discuss about mathematical models in the study of cerebrovascular circulation. I will illustrate to you the benefits that mathematical models can offer for the study of the cerebral circulation. The motivation for building computational models, as you've seen also in the previous presentations, is that the cerebrovascular system is extremely complex, with many different mechanisms that are operating together and that interact in nonlinear terms. In particular, the cerebral circulation occurs within a closed compartment, as we have seen in the previous presentation, with only a limited capacity to compensate for a blood volume change. Moreover, the cerebral circulation is under the control of sophisticated regulatory mechanisms that work to maintain cerebral blood flow adequate to metabolism and function in different physiological and pathological conditions. The veins can collapse, both the intracranial veins and also extracranial circulation can collapse in different conditions. And finally, in the intracranial circulation, in the arterial side, but also in the venous extracranial circulation, we have complex anastomatical pathways. For these reasons, it is extremely difficult to arrive at a complete understanding of brain hemodynamics in simple qualitative terms, using discursive reasoning only. And so mathematical models can have a strong impact in this field. As we have seen in the previous presentation, the first step in building a model of the intracranial circulation is the Monro-Kelly doctrine. That is that overall circulation inside the skull and neuraxis occurs within a closed space with only a limited capacity to accommodate for a blood volume change. And substantially, we have three kinds of volumes: the cerebrospinal fluid volume, the blood volume that can change in different conditions, and other volumes not included in the model that have a very limited capacity to be compressed. In this presentation, I will illustrate substantially three different models that we have built over the years, and I will start with the first, the simpler model, that is described in this diagram. The model is quite simple, since we have just one path for the blood flow entering the arteries, leaving the veins. And the model incorporates the limited capacity of the system through a pressure volume characteristic. The model incorporates the collapsibility of the veins in their terminal portion. The model incorporates the circulation of the cerebrospinal fluid that is produced in the choroid capillaries and reabsorbed at the dural sinuses. And important, the model also incorporates the vasodilation and vasoconstriction of pyoal arterioles that regulate their caliber to control the cerebral blood flow. This is the pressure volume characteristic of the compartment that describes the limited capacity to accommodate a volume change. These have been obtained from previous studies from neurosurgical authors, Avzat, Marmaru in the 70s and the 80s. This is the possible volume change within the compartment, and this is the consequent intracranial pressure change, because any volume change causes the compression of the other elements, a shift, as we have seen in the previous presentation, of CSF, and an increase in intracranial pressure. As you can see, a normal subject has a moderate compensatory capacity. A volume change causes a moderate increase in intracranial pressure. If the volume change increases too much, intracranial pressure starts to increase dramatically. But in pathological subjects, for instance, subjects with head injury, the pressure volume characteristic can worsen dramatically. And as you can see, even a modest change in blood volume can induce an enormous change in intracranial pressure in pathological cases. The second aspect of the model, as I said, is the venous circulation. Here I am talking about the veins inside the skull. As we've seen before, the veins inside the skull can collapse at the terminal portion, substantially the bridge veins, through a mechanism similar to that of a Starling resistor. As a consequence, during intracranial hypertension, we have the collapse of the bridge veins. The venous pressure at the terminal section rises up to the intracranial pressure, and this is the reason why the cerebral perfusion pressure is substantially the difference between the arterial pressure and the venous pressure. The most innovative aspect of the model is that it incorporates autoregulation and generally the regulation of blood flow. As you know, cerebral autoregulation, this is a very schematic curve. Cerebral autoregulation maintains the blood flow pretty constant despite changes in pressure. And here you can see how the model simulates the cerebral autoregulation. The blue line is the model, and the other points are taken from the physiological literature. During a decrease in arterial pressure, we have a vasodilation of pial arterioles. This is the radius of arterioles. And as a consequence of this vasodilation, the cerebral blood flow is maintained quite constant despite pressure changes. But the model also incorporates the effect of CO2, hypercapnia. During hypercapnia, we have the vasodilation of arterioles, this is the caliber, and as a consequence, an increase in cerebral blood flow and an increase in the middle cerebral artery velocity, the velocity in the middle cerebral artery. And as you can see, the agreement between the model and the real data is good. An important implication of this model is that there is a feedback, a positive feedback, named the vasodilatory cascade, a vicious circle inside the intracranial circulation, as a consequence of the mechanisms illustrated above. In particular, if you have a decreasing cerebral perfusion pressure, we also have the activation of autoregulation mechanisms, which induce a vasodilation and an increase in intracranial pressure. The increase in intracranial pressure causes the collapse of the veins, thus further reducing the cerebral perfusion pressure. This is a positive feedback that may have dramatic consequences in pathological cases. Fortunately, in a normal subject, this vasodilatory cascade has no dramatic consequences for two basic reasons. First, there is a good circulation of the cerebrospinal fluid that works to restore the ICP, and moreover, a normal subject has a certain capacity to accommodate the changes in volume. But in pathological subjects, for instance, in subjects with severe head injury, due to reduced cerebrospinal fluid circulation and the presence of other volumes inside the skull, this vicious circle may become dramatic. Here you can see a simulation with the model when the model simulates an acute hypotension, a sudden drop in arterial pressure. In the normal subject, this is the dotted line here, arterial hypotension, of course, has no particular effect on intracranial pressure because we have some compensatory capacity. Here I am presenting just the average values of the quantity over time. We can also simulate pulsating conditions, but I just present average values today. These are 5 minutes. But in patients with a severe reduction of intracranial compliance, for instance, a patient with severe head injury, the arterial hypotension through the vasodilatory cascade may produce a peak in intracranial pressure. In the most dramatic conditions, this vasodilatory cascade may cause the instability of the overall system with the appearance of the well-known plateau waves. An oscillation of intracranial pressure with a dramatic reduction in cerebral blood flow, which occurs in severe neurosurgical patients. With this model, we simulated real patients in the intensive care units with a French equipe a few years ago. Here, the blue line is the model, the red line is the real patient. This is the arterial pressure, the CO2 pressure, the intracranial pressure, and the blood velocity in the middle cerebral artery. As you can see, a small increase in CO2 causes a dramatic increase in intracranial pressure in this patient, and the medical doctors had to restore immediately a lower CO2 pressure to maintain a low ICP. And the model, with suitable parameters, simulate these patterns very well. And this is a second patient simulated with the model. The previous model, however, have some important limitations. In particular, the arterial and the venous sides were very simplified. In particular, in certain cases, there is an heterogeneity among the hemodynamics in the different brain districts. For instance, when there is an occlusion in one internal carotid artery. So we built recently a more sophisticated model which discriminates between the different intracranial districts. The 6 regions perfused by the posterior, middle, and anterior cerebral arteries in the 2 hemispheres. And in the model, we included the effect of the circle of Willis. As you can see, the venous return to the heart is still very simplified here. With this model, we are able to simulate conditions when there is a different hemodynamics in the different districts. In particular, I will show you just one example, the case of a severe stenosis of one internal carotid artery, and I will show you the effect of an hypercapnia in this condition. This figure shows the blood flow in the ipsilateral internal carotid artery, the same side where there is an obstruction, in the ipsilateral middle cerebral artery, in the contralateral internal carotid artery, and in the contralateral middle cerebral artery. As you can see, in the contralateral side, the hypercapnia performed at this instant causes the well-expected increase in blood flow in internal carotid artery and middle cerebral artery. But in the ipsilateral side, when there is the obstruction, the situation is different. The curves from 1 to 5 represent 5 different subjects with an increased severity of the ECR stenosis. If the stenosis is not severe, there are no particular problems. But in case of severe stenosis, we don't have an increase in blood flow in the middle cerebral artery district, despite the hypercapnia. But rather, we can observe a still phenomenon. The blood flow decreases as a consequence of the CO2 increase. The reason is that the district downstream of the occlusion is already vasodilated. This is already vasodilated and cannot further vasodilate due to the hypercapnia. The contralateral district vasodilates and still blood flow from the ipsilateral side. There's model prediction in agreement with the data. You can see the comparison within the model and data in the literature. In particular, this is the still phenomenon, the reduction in blood flow. And finally, I wish to present you the last model that we developed in the last year together with Paolo Zamboni and his equipe, because the previous model had the serious simplification on the venous side, the venous return to the heart. And so we simulated a much more complex model in which there are anastomosis and describe quite carefully the venous return to the heart. Here we have the very simple model of the intracranial circulation, the first model that I have shown you. We can also include the circle of Willis, but there is no reason in this particular case. There is the simple intracranial model, and then we have the 2 jugular veins, the vertebral veins, the azygos system, and also additional collateral vessels that carry the extracranial flow, but also have important collateral anastomosis toward the 2 terminal portions of the jugular veins. With this model, we can study conditions in which the extracranial venous pathway is stressed. And for instance, a first condition can be the posture change. An important point during a posture change is that the jugular veins can collapse as a consequence of a reduction in transmural pressure. and especially the upstream portion of the jugular veins collapse. Here you can see how we described the collapse of the jugular veins. This is the hydraulic conductance. If the transmural pressure decreases, the jugular veins in the upstream and downstream portion can progressively collapse. And so we can study the effect of a posture change. This is just a comparison between the model and the literature. The dark is the model and the white is the literature. This is the blood flow in the jugular upstream section of the jugular veins in supine condition, and in upright condition, the blood flow decreases dramatically due to the collapse of the jugular veins, and the blood flow in the vertebral arteries increases. And there is excellent agreement with the literature. But the next slide shows you more carefully what is happening. This is just the model. The dark bar represents the supine condition, and the white bar, the upright condition. This is the cerebral blood flow. As you can see, during a posture change, the cerebral blood flow does not change because of autoregulation mechanisms. This is the blood flow in the upstream portion of the jugular veins that dramatically falls down in the upright state. Simultaneously, the blood flow in the vertebral veins increases, and especially the blood flow in these collateral vessels increases. But this blood flow in collateral vessels progressively re-enters into the terminal portion of the jugular veins, the last portion, and the terminal portion of the jugular veins are not substantially collapsed. And the final figure, the last one, with this model we can study the effect of stenosis. And here we simulate a dramatic condition, a complete stenosis of some venous vessels. This is the basal condition. This is the sinus venous pressure in the supine condition and in upright state. Why the sinus venous pressure? Because the sinus venous pressure represents the contact point between the extracranial circulation and the intracranial circulation. As you can see, from supine to upright, we can observe a moderate increase in the sinus venous pressure from 6 to 8 mercury millimeters due to the compression of the jugular veins. If we have a stenosis in the vertebral veins, the effect in the supine condition is not particular, but we can observe a moderate worsening of the pressure in the upright state. If you have the stenosis in one jugular vein only, the effect is not dramatic. If you have a stenosis in both jugular veins, we can observe a significant increase in sinus venous pressure, and so, as we have seen in the previous presentation, in intracranial pressure too, up to about 12 mercury millimeters. This is the most dramatic case. If you have stenosis both in the jugular veins and in the zygous system, we have a further increase in sinus venous pressure reflected in hypertension. With this example, I have shown you how mathematical models can be used to simulate physiology and real clinical conditions. In particular, a mathematical model can help us to reasoning about complex phenomena, which may be useful in educational problems in order to improve our understanding of the physiology, and we hope also in perspective in clinical practice. An important point is that these models are a very good repository of our knowledge, because much knowledge that is spread in the literature, anatomical, physiological, neurological, clinical, behavioral, and so on, can be summarized in mathematical models in a single theoretical framework. And in this way, models are exceptional instruments to help our reasoning of these complex problems. Thank you.
Thank you, Professor Ursiner, for that excellent talk. Are there any questions from the floor? Well, I have a question. You mentioned that in pathology, the ability of the cranium or the brain to adapt to compensate for increases in pressure was inhibited. So I was just wondering, I've noticed a number of papers both old papers and recent papers with MS patients who change their posture, turning to one side or the other of the neck. And there are old papers about increases, very temporal, transient increases in intracranial pressure with changes in head position. I wonder if those would be more accentuated in patients who had maybe MS or some other pathology. Could you maybe comment on that?
Yes, I think that the maneuver that you are describing causes an increase in venous pressure and so an increase in intracranial pressure. And I think that in pathological patients, this problem may be substantially accentuated.
So it may be that they can't compensate even for very small movements and therefore have some effect.
Even a few milliliters change in a volume cannot be compensated if you have a tumor or if you have a severed head injury. And this may cause the effect that I have illustrated in the first figure, a peak in intracranial pressure that is moderate in normal subject, but may becomes dramatic in subject with a reduced compensatory capacity. And that is evident in neurosurgical intensive care units.
All right, thank you. There's a question at the back there, yeah?
Yes, that's right. As you know, we have constructed a global model for the human circulation that contains the venous system, arterial system, CSF, microvasculature, heart, and the pulmonary circulation. Now, this globality of the approach, I think, is important to stress because it has a predictive capability. So you have to have the full system working in a coordinated way in order to compare with experiments. So my question is, what do you think about the necessity of a global model to do the simulations? And number two, parameters, because all these problems have a tremendously large number of parameters which are unknown, okay? Now, how do you estimate these parameters? Because this is the crucial thing. You can choose them to fit agreement with experimental results, but that is probably not the right way to do it. So how do you do it?
Yes, the first question, I agree with you. Substantially, the models must be tailored to the particular application and to the particular data. So in certain cases, we should use simple model. In other conditions, we should use more complex model. Of course, we also have models with the overall circulation, baroreceptors, chemoreceptors, and so on. And in particular conditions like hypercapnia, it would be very beneficial to have an overall model of the entire systemic circulation. It depends on the application, but I agree with you that in certain cases, this may be very, very important. As to the second question, there are many parameters, but through a sensitivity analysis, that means to understand what is the effect of a parameter change on the model, we decided which are the more influential parameters for that particular maneuver. There are substantially 5 or 6 parameters that are very influential to study patients in intensive care units, and we focus the estimation on that subset of parameters, the 5 more sensitive in that particular condition. And as it was our estimation, 5 or 6 parameters.
Great. Thank you very much, Dr. Orsino. That was very nice. Now, Steve Alexander is going to talk to us about fluid dynamic influences on cerebrovascular endothelial activation responses. So we're going to have a little computer hookup here, and then Steve will be right with us.
I'd like to thank the organizers for letting me present some of this work. I'm going to be talking about fluid dynamic influences on cerebrovascular endothelial activation responses. Basically, this is work with cultured endothelial cells that's trying to model some of the stuff that you've been seeing this morning. And we've used human and mouse endothelial cells, and we've created in vitro models that maybe recapitulate some of the findings that you're going to see. My disclosures, I'm working with Appios Corporation, and we're funded through LSU and the neurology department at LSU in the School of Graduate Studies. I'm going to talk to you about flow shear and endothelial gene modulation and differentiation and tight junction and vascular homeostasis, and how this relates to MS and Alzheimer's disease potentially.
and really how vascular shear is triggering all of these responses. We're using endothelial cells from human brain and mouse that have been exposed to laminar flow and non-laminar flow at low and high levels. And one of the interesting things that's relevant to this discussion is that we're seeing amyloid precursor protein expressed abundantly by endothelial cells from the brain, and it's released into endothelial microparticles, which are bits of the membrane. I'm going to talk about it in my second talk in response to fluid shear. LIB1 and KLF4 appear to be some important products that are responding to high and low shear that are transferred into endothelial microparticles. And the tight junction protein occludin is expressed in endothelial cells in response to fluid shear, and that is actually transferred into microparticles. So it's kind of an interesting thing. So abnormal flow and shear patterns, I'm sure we've seen this morning and are quite convinced that blood-brain barrier disturbances, abnormal endothelial signaling, changes in endothelial shape, changes in endothelial growth regulation and gene expression, and smooth muscle gene expression, vessel remodeling, all of these things contribute to vascular stress and neurodegeneration. So what is the link? Well, we think that in the brain, altered shear and flow patterns lead to disturbances where we might actually be having breakdown of the blood-brain barrier or situations that may trigger or predispose towards this. So we did two models. One is the shear ring model, which is a laminar oscillating shear model. It uses very large surface areas that allow us to do Western blotting that we couldn't really do in parallel plate models. And the second one is a microcarrier-based model that we use to grow cells on these very small beads. And I'll tell you about both of those. The laminar shear, the laminar flow shear ring is a 100 millimeter dish, and into that we put medium, and then that dish gets swirled such that the outer level of the ring actually experiences a higher level, and the inner experiences a relatively low level. And when we look at the cells on these, what you can see is compared to static cultures, what you see is when they're sheared, they actually align parallel to the direction of flow. And this is an interesting thing that this is seen before. And if you look at the shear profile in this, which is modeled after the parallel flow plate approximation, when we induce the swirling of this, what you see is that the shear goes, at a low level of media, it goes from 0 to about 6 dynes per centimeter squared, and you can see that. And in the center, this represents, right in this region represents the center of the track, and then you have the greatest resistance at either end of that, and this is the derivation for the dynes that we see. And we do the same thing at a different level of fluid, and again, we get the same basic profile, but we see a different level of dynes that are actually being produced. And that's the different level of shear stress that we see in this model. So if we do this, one of the things that we see is that the endothelial cells actually, it's really interesting that endothelial cells express amyloid precursor protein. And they increase it in response to shear stress, and they actually put it into microparticles, which are bits of the membrane that are being released. And interestingly, they release this into, they release this from the cells, and they actually put it both into the medium, and then they also put it underneath themselves as well. That is, if you were looking at this three-dimensionally, this is being excreted into the brain, which is an interesting thing that we hadn't actually recognized before. With respect to the shear-dependent transcription factor KLF, we see that goes up in endothelial cells, and it's transferred dramatically into microparticles as well. I'm going to give you some. Now, when we look at KLF2, another shear-dependent transcription factor, that is not transferred into microparticles. And this all has important effects on shear-dependent responses of the endothelium. If they are losing these shear-dependent transcription factors, they are going to have an altered response to fluid shear. Yes? So now we consider laminar versus non-laminar shear. Let's consider the microcarrier model. So we have cells that we grow on microcarriers either under static conditions in dishes, or we spin them at 36 RPM, or we spin them at a much higher rate, about 88 RPM. And this is non-uniform, this is non-laminar shear. So we grow the cells under these three conditions, and then we have our microcarriers with cells. We isolate the microparticles from these. We do immunofluorescence, Western blotting, and some flow cytometry to see exactly what's going on with them. This is what they look like when they're grown on them. They're very pretty raspberry-like things. And the flow approximation is based on Ismati's approximation, but we used a slightly different mathematical calculation for it that's based on the height. That's based on the height of the fluid level and then the distance to the impeller. And when we do this, what we see is when the cells are sheared at a relatively low level of shear, they actually decrease their metabolism. They're actually a little bit happier, and this may correlate with the nitric oxide production. When they're spun even faster, that effect is actually lost. That's an interesting thing. It says that there may be an optimal level of shear that these things can actually tolerate. Now, if you were to look at the shear profiles in these beads, we're seeing, of course, because these are being spun, we're seeing in the static, we don't see any shear at all, but if you look at the low, you're getting a distribution of shears between 0 to about 1.6, and then in the high, from about 0 to about 0.8 in the low shear, and up to and exceeding 1.6 dynes in the high shear. And then I want to tell you about endothelial microparticles. Endothelial microparticles contain a lot of the molecules that are found on the parent endothelial cells that they're derived from. Okay, so when you look at these cells that are releasing microparticles are actually releasing not only transcription factors, but they're also releasing microRNAs into these. And what you see on the top are cells that they've actually been incubated with microparticles that contain fluorescein diacetate from another cell culture, and these things are being taken up from cells. And interestingly, the MER 155, 100, 106A and B, these are microRNAs that are associated with inflammation, and they may be transferred from one cell to a distant site. It's kind of interesting. Another thing that microcarriers may do, when we mix these into gels with vascular smooth muscle, it's very interesting to us that what we saw was that when we add a small amount of microparticles, we increase the contractility of vascular smooth muscle. But when we add more, when we exceed a certain level, now we actually impair, right? I'm going to show you here. We are actually impairing the contractility of vascular smooth muscle. So these things may have effects on vasomotion as well. We're just recognizing that. So if you look at the shear-induced release of microparticles from brain endothelial cells, low and high RPM releases similar levels and not a dramatic increase. Compared to cytokine treatment, and I'm going to be talking about this at 4 o'clock, we get a much larger increase when we treat with cytokines. So the question is neurovascular disease a shear-dependent phenomenon? Probably not exclusively. Is it a cytokine or inflammatory-mediated phenomenon? Probably not. But a mixed stress of these two kinds could provoke an extremely important and dramatic response in endothelial biology. To get back to the effect of flow and shear, this is the production of nitric oxide. We only see significant increase in the production of nitric oxide in the low shear. When we get to higher shear, now the endothelial cells, despite being exposed to shear, which we know triggers nitric oxide release, now they actually stop making nitric oxide. And it's probably the nitric oxide that is responsible for suppressing the endothelial metabolism. This is an important thing we actually hadn't recognized before. And this represents nitrite, not nitrate. There's sulfanilamide did not enhance recovery of these tracers, so there's no nitrate. It's just, these are all NO2 species. So if we look at the endothelial genes and transcription factors that are affected by shear stress, again, I said that we had KLF2 and KLF4, and we also had APP being affected by these. Let's consider what we got. This is a lot of Western blots that I'm showing you here, but I think you can see that in the cells exposed to high amounts of shear, they're making a lot of amyloid precursor. And here, this is showing that these microparticles normally they're not normally expressing that much in the microparticles, but here they're actually delivering a large amount of it in. KLF4 is also delivered into microparticles exposed to shear. Here's eNOS, which is being, endothelial nitric oxide synthase is being delivered into microparticles, so they're losing it. It's possible that the higher level of endothelial nitric oxide may be responsible for the lower amounts of NO that we see. And here, this is a occludin tight junction protein being induced and then shed. And an important finding that we see here is this is caveolin. I think we heard yesterday from Dr. Damon about caveolin. These microparticles, now we can recognize them as endothelial, these are shed endothelial caveoli, because they are actually expressing large amounts of caveolin in response to shear, and then they're dumping lots of this stuff. Live 1, we're going to talk about this at 4 o'clock. This is the lymphatic vascular endothelial receptor. This is also being induced and being released into cells. And just to show you, this is PROX. I'm going to talk about this. I just got this data from my postdoc. The PROX is a transcription factor in lymphatic endothelial cells. We'll talk about this at 4 o'clock. And this is being actively induced. It's changing the phenotype of these brain endothelial cells to have more lymphatic properties. And the significance of that is going to be discussed in the lymphatic section of the talk. So when we look, we see that the microparticles exposed to shear release APP, KLF4, KLF2, occludin tight junctional protein, eNOS. Now, if I were to look at the significance of this is some work that this is some work that we did in collaboration with Marie-Luce Beaucheton, who couldn't be here. But what we see is that the KLF2 and KLF4 expression is normally high in these are vessels that are taken from normal or MS individuals. And it seems as though these beneficial transcription factors may actually be reduced in individuals with MS. So we're trying to understand this actually right now. Brain endothelial APP is actually, just to show you here, this is actually the full-length endothelial amyloid precursor protein. It's the 130. Now, if you have, this is evidence, I would say this is evidence for smoke, but not fire. This is not beta amyloid. This is the precursor for it. Now, should this be processed in a particular location by appropriate enzymes, such as beta gamma secretase, you may wind up with this. So it really depends on where these where do these microparticles wind up, which is an important consideration. Just to show you here, this is the static cultures, the low speed and high speed spinning cultures. You can see this is APP being released. Sorry, this is APP. I'm trying to get this. The APP here is showing up at cell-cell borders. The question is, why would these cells be making APP? It actually may serve some functions in cell-cell contact. And here, this is with nuclear stain, showing this is a perinuclear distribution, and there's more of it there. So the idea is that vascular amyloid in neurodegenerative disease could represent a deposition of APP-bearing microparticles that are delivered to the extravascular space. With this in mind, part of this discussion is about drug discovery. One of the things we've noticed is that you can prevent the processing of APP into beta amyloid by a steal phenomenon that is induced by this drug here, which is bryostatin, which is a drug that we're working on for Alzheimer's disease. And it prevents the APP from hanging around and being available to be processed into beta amyloid. Right now, we're transfecting this tracer into several different endothelial lines so that we can actually examine the phenomenon of the processing of it. Okay, just to show you, that drug used in mice that actually have Alzheimer's disease, this is showing you that this is activating the alpha secretase that's beneficial in Alzheimer's phenomenon. And bryostatin works very well as an activator of that pathway. And when mice are pre-treated, when the APP-PS1 mice are actually treated with this drug, for 2 weeks, they show significant improvements in their performance that are unrelated to motoric influences of these. And this is work that we published in current Alzheimer's research earlier this spring. Lastly, just like to say, I think that this is something we did on intra-abdominal hypertension. If we are to hyperpressurize, and this is stuff that Dr. Beggs has been showing, if you were to hyperpressurize the abdomen to prevent restrictive outflow, we see a tremendous difference in the amount of tracer that can actually be delivered to the brain, right? And one of the models that so even modest changes in outflow restriction can impair this blood-brain barrier. One of the things we're doing in collaboration with Alan Dardick is we have what I think is the first mouse model of venous restriction, which is the aortocaval fistulae. In this, we actually make a puncture between the aorta and the vena cava, and it seals up. And what it produces is a pulsatile flow profile above the fistula that is actually reminiscent of some of the phenomena that we've been discussing. So you get a pulsatile shear and pressure in the vena cava, which is communicated upward towards the CNS. Maybe it's producing an abnormal flow and shear pattern. So it's a potential mouse model of a venous pressure disturbance. So right now we're looking for alterations in inflammatory markers and vessel composition. So in summary, shear alters endothelial arrangement, causes transfer of these microRNAs into microparticles. We saw several different important mediators changing: APP, KLFs, caveolin, occludin, enos, and live. And they represent fluid phase caveolae from these cells. And we think that APP-laden microparticles may contribute not only to Alzheimer's, but we actually see this in MS-like conditions. And ultimately, targeting of APP processing may be an important target for neurovascular disease, not only for Alzheimer's, but for other conditions as well. And I'd just like to thank you for your attention.
Thank you, Steve, for that. Have we any questions? Paolo.
Yes.
Great presentation, Stephen. Did you measure or assess the PDGF? Because we found in ex vivo models that this is expressed by turbulence and suggests something like also repair, not always offensive flow modulating injury in the endothelial cell.
I think PDGF is a really interesting, it's a really interesting target to consider. We haven't, I mean, at this meeting, there are a lot of different targets that we haven't yet thought to look at have come up. Endothelin, we're going to hear about that this afternoon. I think clearly endothelin-1 is something that we would really like to measure in response to even, as you say, in response to normal shear. And then you push it a little bit beyond, maybe, you know, it's probably the distribution of a large number of these different mediators that's going to trigger this. It's a good idea.
Right. I think we need to move on time-wise, so I think we'll move on to our next speaker as Steve kind of gets the computer sorted out.
Got it.
Our next speaker is one of the selected platforms, and it's Dr. Cherevo, and he's going to talk on cerebral circulation in patients with MS, a color Doppler study of extracranial arterial and venous vessels. So over to you.
Thank you for the presentation. Good morning. I'm going to present some preliminary results of our ongoing work about cerebral circulation in patients with multiple sclerosis, a color Doppler study of extracranial arterial and venous vessels. Causes and pathogenesis of multiple sclerosis are still not completely clear, but in recent years, many works have highlighted the higher risk for cardiovascular events, in particular ischemic stroke in MS patients, that may be at least in part related to global cerebral hypoperfusion, not only of the damaged white matter, but also of the normal appearing white matter. Moreover, many groups have focused on cerebral venous drainage in MS, and firstly, Zamboni and colleagues found an association between MS and a condition they defined as chronic cerebrospinal venous insufficiency. Since then, many groups focused on CCSVI, reporting conflicting results as shown in the panel on the left. And finally, a previous contrast-enhanced ultrasound work conducted by our group was able to detect a prolonged cerebral circulation time of blood through the central nervous system of MS patients. For these reasons, we hypothesized that an extracranial arterial and venous vessels examination by quantifying arterial inflow and venous outflow and by measuring intima media thickness of the common carotid artery may let us further understand the relationship between MS and cerebral circulation abnormalities. So we aim to compare a group of MS patients with healthy controls in terms of cerebral arterial inflow and cerebral venous outflow, performing a Doppler sonographic examination of the neck vessels. Moreover, as intima media thickness of the common carotid artery is known to be an index of arterial wall atherosclerotic damage, we aim to evaluate if this parameter may be proposed as a useful tool to detect the increased cardiovascular risk known to be present in MS patients. Finally, we tested whether there is any correlation between arterial and venous color Doppler measures and clinical parameters of our cohort. To do so, we studied 105 MS patients and 65 sex and age matched healthy controls. And all patients fulfilled revised McDonald criteria for MS diagnosis, and those with concomitant cardiovascular diseases were excluded from our cohort. Healthy control did not show either familiarity for MS or cardiovascular diseases, and all subjects underwent a Doppler sonographic examination of the neck vessels, which was performed at least 30 days from the last relapse of the disease, with a Philips U22 ultrasound system and a 9.3 linear array probe. For what concerns arterial measures acquisition, we chose to record all parameters on patients in supine position. In addition to cross-sectional areas and Doppler waveform parameters, we chose to record intima media thickness of the common carotid artery. In particular, we calculated the common carotid artery posterior wall intima media thickness, and to do so on a longitudinal section of the vessel, and to do so we used a semi-automatic method that provided us maximum and average intima media thickness of the common carotid artery posterior wall. Subsequently, cross-sectional areas were acquired along with Doppler waveform parameters. In particular, internal carotid arteries measures were acquired at least 1.5 centimeters away the carotid bifurcation, and vertebral arteries measures were acquired in the V1 tract of the vessel, sampling 4 cardiac cycles of each Doppler waveform to obtain each vessel Doppler waveform parameters, such as peak velocity, mean velocity, and blood flows. Finally, cerebral blood flow was calculated as the sum of blood flows in both internal carotid arteries and vertebral arteries. According to postural changes of venous district hemodynamics, we chose to record all venous parameters on patients in both supine and upright positions. In particular, cross-sectional areas were acquired at 3 levels for internal jugular veins: J1, the lowest portion of the vessel; J2, on an axial section of the vessel in which thyroid parenchyma was visible; and J3, the most cranial portion of the vessel. For vertebral veins, cross-sectional areas were recorded at the most caudal portion of the vessel before its entrance in the transversary foramen. Doppler waveform parameters were then recorded for internal jugular vein at J3 level to avoid extracranial collateral influence, and for vertebral vein on the most caudal portion of the vessel. Moreover, we calculated total cerebral venous outflow as the sum of each blood flow of each examined venous vessels, and inflow normalized outflow was calculated as the ratio between total cerebral venous outflow and total arterial cerebral inflow. So we applied a non-parametric statistical test to evaluate if there was any differences in terms of intima media thickness of the common carotid artery and cerebral blood flow between patients and healthy controls. We found no significant difference in terms of intima media thickness measures, while we found a slight but not significant reduction in terms of internal carotid arteries and vertebral arteries blood flows that led to a significant reduction of cerebral blood flow calculated as the sum of each cerebral afferent artery blood flow. Here in the table, venous analysis results are shown. In particular, consistently with literature, we found our healthy control cohort showed an right internal jugular vein blood flow dominance, which is not preserved in our MS patients cohort, highlighted by the significant reduction in terms of right internal jugular vein blood flow. This led to a significant reduction in total cerebral venous outflow, both in supine and upright positions. But when corrected for the arterial inflow to minimize the inflow influence on the total cerebral outflow, we found no significant difference between groups. Moreover, no differences between groups was found in terms of arterial or venous vessels CSAs, cross-sectional areas, and no correlation between clinical parameters and Doppler ultrasound measures was found. In conclusion, intima media thickness does not differ between MS patients and healthy controls, suggesting that the increased cardiovascular risk known to be present in MS patients may not be related to arterial wall atherosclerotic damage, so that intima media thickness of the common carotid artery may not be proposed as a useful tool for cardiovascular risk assessment in MS. Moreover, arterial inflow is significantly reduced in MS patients, and consistently with literature, our healthy control cohort showed a dominant right EJV drainage pattern, which is not preserved in MS patients, and this led to a significant reduction in terms of total cerebral venous outflow, both in supine and upright position. But when normalized for the arterial inflow, it shows no differences between groups, suggesting that the decrease in terms of total cerebral venous outflow may be, at least in part, related to the decrease of the arterial inflow so present in our cohort. As future perspectives of our work, we aim to enlarge our cohort to be able to compare different MS clinical form cohorts, to correlate Doppler ultrasound data with MRI data, to perform a more accurate cardiovascular risk assessment, and to correlate our results with biohumoral measures such as endothelin-1 and homocysteine blood concentration known to be increased in MS. And finally, we aim to evaluate if there is any differences between MS patients and healthy control in terms of CCSVI incidence. Thank you.
Thank you, Dr. Servo, and thank you for staying on time. Any questions? Yes.
Okay, nice presentation. I take care of a lot of MS patients, and in your presentation you mentioned that there was no correlation between the findings of your study and clinical features. Is that correct?
Yeah.
So then there's this question, clinicians, neurologists are going to ask you, why should we do this to begin with, this study, if there is no correlation between the findings and the clinical features? How does a study of this venous system can help us to assess our patients and improve their care? That's one question. The second question is, have you looked at these patients when they have clinical relapses and they have new contrast-enhancing lesions on their MRI at that particular time? Have you looked at their baseline venous parameters versus during relapse to see if there is any change? Because if you can show that change, that's a magnificent finding.
Yeah, for the second question, I can say we didn't, but I think it would be a great improvement of our work. I think that the clinical value of this work is still not completely clear, so we should enlarge our gathering of parameters, data. As I said, we should correlate our data with other biohumoral measures like endothelin-1, homocysteine-1, and to better understand what relationship may be between these cerebral circulation abnormalities and MS. So I don't think this could have a great clinical value.
Yet, at this moment.
Yet, at this moment.
So the other issue is, we know that if patients with MS, they relapse, they give them immediately IV steroids, corticosteroids, Solimedrol. And there is ample evidence that the effects of the steroids is way beyond the immune system, and the steroids interact actually with the cerebrovascular system. So that would be another point to look at the effects of treatment with Solumedrol, basically the standard regimen, and your venous findings at the baseline and after the treatment.
In fact, this is one of the other aim we have, to correlate the results we reached with the therapies the patients are following. So,
all these
as I said, it's an ongoing work. So
yeah, all these studies are great. We just have to create a link between what you find and the actual patient.
As I said, it's an ongoing work, so we will complete our work with your suggestions.
Thank you.
Great. Thank you very much, Dr. Trevor. Okay, our last speaker before a break. I want to remind everyone at the end of this talk we're going to have lunch, and it'll be a buffet, and I'd like you to move quickly through because we're going to have a working lunch and a presidential address, some gold medal award, obviously some societal business and some other awards. So it's going to be a lot of interesting business and a lot of interesting recognitions I think you'll enjoy. So we'll do the buffet lunch as quickly as possible and return in for our business meeting. So our last 10-minute talk is by Adelaide Greco, again part of the selected platform, ultrasound-guided surgical procedure for internal and external jugular veins, occlusion in mice, and we're going to hear the preliminary results.
I will be very quick. I want to thank the ICNVD committee and especially Marco Salvatore and Marcello Mancini that are my scientific supervisor. I will show you a technical approach for the dissection and the occlusion of neck veins in a mouse model, and I will show you some images of high-frequency ultrasound for the evaluation of the procedure efficiency. Vascular abnormalities in mice models of neurological disease have been widely investigated. However, most of the studies present in literature are related to the arterial system. The blood returns from the central nervous system back to the heart via several venous systems in the neck and along the spine. And this is called like extracranial venous drainage system. I don't know where is the pointer. I would like to show you just this is? Oh, okay. Okay, this is easier. This is an high-frequency ultrasound image. I want to show you some difference with the human anatomy. These are all salivary glands. This is the thyroid. This is a real scale. So the thyroid of mice is of 3 millimeters of diameter, and so also vessels is very difficult to investigate. This is the carotid, the internal jugular vein, the external jugular vein, the vertebral artery and the vertebral vein. So the human circulation system differs from that of the mouse in both structure and position. If you look at the internal jugular vein in humans, it seems to be very big. Instead in mice, as we can see from this MRI angiography, courtesy of Dr. Palma and Dr. Tedeschi, my colleague, is very little. Moreover, it's very close to vagus nerve, so it's very complicated just to analyze it. Moreover, the external jugular vein also goes into as a two branch, one that goes directly into the brain and another one that goes in the posterior facial vein. So the venous outflow is very different from the human one. To evaluate an animal model of venous occlusion in order to assess the correlation between venous stasis and the development of neurological disease, we use an high-frequency ultrasound machine, Vevo 2100, that is an high-resolution system, to assess the feasibility of electrocoagulation for the induction of venous occlusion in mice. We used 14 C57 black female of 6-week-old normal mice. 4 mice underwent to the occlusion of the internal jugular veins, 4 underwent to a bilateral occlusion of the external jugular veins, and 4 underwent both the external and internal. As control, we used 2 mice as sham-operated mice. All procedures were performed under general anesthesia with isoflurane plus oxygen. Blood venous flow was evaluated before and after surgical procedure by color Doppler high-frequency ultrasound with a 40 MHz probe. We use an electrosurgical equipment mounting a small electrode for monopolar coagulation to induce the venous occlusion. So it's just to understand the dimension. This is the carotid that here just we move away to show you the internal jugular vein that is very close to the vagus nerve. The external jugular vein runs instead in the salivary gland, and it is a little bit more visible than the internal one. As I explained before, we use the color Doppler high-frequency ultrasound just to see the flow before and after surgery. So this is the carotid flow before surgery. This is the internal jugular vein. This is the external jugular vein. And also we have the artery and vein of the vertebral artery and vein, and a little zoom of the neck. As our result, 2 of 14 mice underwent pulmonary complication during the surgical procedure. Therefore, the mortality was of 14%. The internal and the external jugular vein were very well identified with color Doppler prior and after the surgical procedure. In all cases examined, high-frequency ultrasound allows us to confirm the absence of flow in the obstructed veins after the electrocoagulation procedure. All survivors are under neurological examination to assess the brain damage secondary to neck vein occlusion. And here are some images that we use just color Doppler frequency ultrasound to see if there was flow in our ligated veins. This is no flow to kind of velocity of blood for the internal jugular vein. You can see no flow for the external jugular vein. And this is the sham-operated mice. Here you can see the surgical access, but all the flow is well conservated. In our study, we evaluate the feasibility of ultrasound-guided surgical procedure that resulted as a low mortality technique and showed an efficiency of 100% of survivors. As the neck mouse veins anatomy is not similar to human, in vivo imaging of normal neck vessels is necessary for the evaluation of animal models. Further studies are in progress to evaluate brain damage secondary to the occlusion of extracranial veins in mice. What we hope to go in the future study is to make also a comparative work between MRI and ultrasound to evaluate these mice before the surgery and after the surgery, and to see if collateral vein appear also if these mice in time develop neurological signs. And furthermore, we will analyze also an animal model of chronic encephalomyelitis in which we're going to perform a ligation of the external and internal jugular vein to see if there is an involvement of the occlusion of veins in brain damage in mice. Thank you for your attention.
Thank you, Dr. Greco. We'll look forward to hearing a follow-up maybe next year on this. We have a couple questions, Steve and then Hector, and then we'll break for lunch.
That was fascinating. I've seen people talking about this model before. Just curious, preliminarily, do you care to comment as to whether you see any disturbances behaviorally, or is there a facial congestion that you see in these animals?
Right. When we perform the first ligation of the external jugular vein, we have an edema of all facial tissues, but this edema disappears just in 2 days. When we, in a couple of days, now the animal is well-being. When we ligate both the external and the internal jugular vein, the mice recover slowly, really slowly. But I think that I imagine to have neurological sign in 2-3 months, not very early. Right now, animals are under observation. We do all the neurological exams that we used to do in EIA models, on animal models of multiple sclerosis that we have in our lab. But right now, you know, they seems to be fine, so we will see.
Hector.
She already answered the question.
Okay.
Okay.
Thank you very much. Very nice. Okay, let's go on to our lunch. Come back as soon as possible, and we will start with the presidential address. awards, and business.